and 55 patients of non-ACS patients had semi-equivalents. Now, what were the semi-equivalents which were considered in the study? So, these are the few semi-equivalents which were considered in this study. That is a De-Winter's pattern, hyperacute T waves, isolated T wave inversions, ST segment depressions, resting U wave inversion, low QRS voltage, Wellen sign, ST segment elevation in lead area. So, these were the semi-equivalents which were taken into consideration. Out of 48 patients which had these semi-equivalents, finally 79 patients turned out to be having acute coronary syndrome. As you can see, 55 patients which were considered to have semi-equivalents, out of which only 64 patients were diagnosed as non-ACS patients. So this is quite a bit, quite a glitch what we can see here, as there is a significant number of patients which were considering as STEMI and sending them for an immediate coronary angiography, but still out of which 64 had non-ACS. That means there could have been another cause for his out of hospital cardiac arrest. So the conclusion what was made in the study was isolated T wave inversion and Wellen sign had high specificity for ACS with 0.95 and 0.92 respectively, and the data accuracy of STEMI equivalents for the diagnosis of ACS was low among patients with out of hospital cardiac arrest. That means that we still have to think whether all these ECG patterns what we are getting at the end of our out of hospital at the end of ROSC for such patients, do we still have to send them for coronary angiography or not? The next study which I will be talking on will be on prophylactic platelet transfusion before central venous cannulation for severe thrombocytopenia. Is it required or not required? So this study was conducted in again it was conducted in the Netherlands. It was released in it was a randomized open label multi-center study in Netherlands, again published in August 2023. It was also called as the PACER trial. The research question what we had was, if platelet count was between 10,000 to 50,000 cells, he is receiving a prophylactic platelet count better compared to, he is receiving prophylactic platelet count better, not inferior compared to administration of platelets. The intervention what they did was transfusion of 1 unit platelets prophylactically for all these patients. So the control group was the patients which had received a prophylactic platelets, and the case group was the patient which did not receive a prophylactic platelet yet underwent a central venous cannulation. Now the outcome of this study was, primary outcome was to check whether there was grade 2 grade 4 catheter related bleeding transfer bleeding. So what do we mean by grade 2 to grade 4 is that grade 2 is when there was slight bleeding, slight oozing, but it was easily controllable. Grade 3 was there was hematoma formations. Grade 4 was death of the patient. As you can see here, 4.8% of transfusion group had grade 2 to grade 4 catheter related bleeding, whereas 11.9% of non-transfusion group had grade 2 to grade 4 catheter related bleeding. There was also no significant, however, see, if we see the primary outcome, we can gauge that there was some amount of complication in the no transfusion related group. However, there was no significant difference in the risk of grade 2, grade 3 to grade 4 catheter related bleeding, which was just 2.1% versus 4.1%. The hematoma occurrence, which was 12.2% versus 18.9%. The ICU mortality, which was 57 versus 52%, and hospital mortality related bleeding, 28% versus 32%. So even though out of the primary outcome we can see that yes, we can decrease the grade 2 bleeding, grade 3, grade 4 bleeding was still not much of a difference. So, but still the conclusion was withholding platelet transfusion before central line placement in those patients with platelet count of 10,000 to 50,000 resulted in more CVC related bleeding than prophylactic platelet transfusion. So we all know that fresh frozen plasma transfusion is not much beneficial for patients with thrombocytopenia and DIC, or even in case of coagulopathy patients. However, this study still told that we can do prophylactic platelet transfusion for patients before placing the central line, when the platelet count is between 10,000 to 50,000 platelets. The next study was the thrombolytics for minor stroke. So do we really need to thrombolyze patients for minor stroke? So the minor stroke definition which was there in the study was any stroke where the NIHS grade was less than 5. So this was again a randomized multi-center open-label Aramis trial which was conducted in in China, published in June 2023. The link to the article is present in this in this sheet. Now the research question which was is dual antiplatelet therapy better than intravenous thrombolysis in patients with minor acute ischemic stroke? We all, every day in our day-to-day practice, we see so many patients with acute ischemic stroke, at least a day, at least 1 or 2 patients per day, or at least 1 patient per shift. So such patients, most of the patients, we are also considering neurologist's opinion also before thrombolyzing such patients. But do we actually require, or do we actually need to thrombolyze such patient is the question. So the intervention which was conducted in this study was that they had divided into 2 groups, that is the dual antiplatelet receiving group and the dual antiplatelet receiving group plus the thrombolysis group. So the dual antiplatelet receiving group, the DAPT group, received clopidogrel 300 mg stat followed by 75 mg OD for 12 days, plus aspirin 100 mg stat followed by OD 100 mg for 12 days. The next group, the thrombolysis group, had the same DAPT plus they received antiplatelets. Now the outcome which they measured was very interesting because they had a very broad and open-minded and a very outcome which had excellent functional outcome based on the modified ranking scale. So modified ranking scale again, as we know, it takes from 0 to 6. So they had taken this excellent definition as any modified ranking scale either 0 or 1 at 90 days. So they almost prospectively studied the patients for 90 days, so that is almost 3 months. And at the end of 90th day, they found out, they came across the ranking scale and they had put across the ranking scale. The secondary outcome was bleeding, any death secondary to the marketplace. The results which they obtained were total patients were 519 patients, out of which 93.8% and in the DAPT group had excellent functional outcome, whereas 91% of patients in DAPT plus lysis group had excellent functional outcome. As you can see, there is not much of a difference, but it is extremely important. It's extremely important as an emergency medicine perspective, also in the patient perspective, because we all know thrombolysis is not a very cheap or a very low-cost procedure and intervention, which costs thousands and lakhs together for patients. Another thing what they saw was the risk of intracranial hemorrhage, which was only 1 in patient in DAPT group and 3 in DAPT plus lysis group. So if we see the excellent functional outcome, we can see that the DAPT group had 93.8% excellent functional outcome, which was much more than the DAPT plus the thrombolysis group. So the conclusion which they made was patients with minor non-disabling acute ischemic stroke patients presenting with 4.5 hours of symptom onset, DAPT can be considered instead of IV altiplase. Again there were many problems or many remarks in this article which told that the involvement of dominant hemisphere or the involvement of dominant limb, involvement of any bigger territory or possible involvement of worsening of symptoms. So these are the few limitations which they had, but again they have not given any consensus telling that yes, if it is less than 5 NIHs, do not thrombolyze, go for DAPT. They have just told that it can be considered in such patients. Next coming to the next AAST guidelines. So AAST, as we know, has given guidelines for trauma to blunt trauma to the liver, blunt trauma to the spleen, kidney. It has also released AAST brain injury guidelines, also called as the big guidelines. So this study validated the big guidelines in their article. So this was again a prospective observational multi-institution trial across 9 levels, 9 level 1 and level 2 trauma centers. Now, what did what was the research question? It was validating disposition of traumatic brain injury patients based on big guidelines. So as you all know, again, traumatic brain injury is again a bread and butter for all the emergency medicine physicians. We see at least 10 to 20 patients of TBI in 1 or 2 days put together. So how do we dispose such patients? Do we have to admit all mild traumatic brain injuries, or can we safely discharge patients, mild traumatic brain injury patients, or how do we monitor moderate traumatic brain injury patients? We already have a GCS scale. Based on GCS scale, the division of mild, moderate, and severe traumatic brain injury according to ALS. But what the big guidance gave was, they divided the patients into big 1, big 2 and big 3. So big 1 had basically had a predominantly a less amount of severe patients, which had, as you can see, the SDH less than or equal to 4 mm, EDH less than or equal to 4 mm, the interbank and MRI less than or equal to 4 mm. And the big 2 had a slightly bigger size, and the big 3 had a much larger, which might require neurosurgical intervention. The therapeutic plan which they did was which they did for big 1 was observation for 6 hours followed by discharge. Big 2 had hospitalization and observation. Big 3, yes, hospitalization. The repeat CT was not conducted for big 1, big 2 initially, and then they followed up checking whether these patients required a repeat CT or not. Whereas the big 3 patients, yes, they underwent HCT, and most of them had to undergo a neurosurgical intervention. Now the intervention which they did was stratifying to big 1, big 2 and big 3, and they studied the primary outcome as requirement of neurosurgical intervention, and the secondary outcome as how many patients clinically deteriorated, how many patients had to go on repeat HCT, how many patients came back to the emergency because of the pain or other symptoms, and how many patients had 30-day readmissions. So the results of this study were, they had taken totally 2,432 patients, out of which they had divided 301 into big 1, 1,295 into big 2, 1,437 into big 3. And as you can see, 4 out of 301, that is only big 1 patients, only 4 patients required a repeat HCT. 2 patients out of 295, that is big 2, had worsened clinically. 21 patients had progression in big 2 requiring a HCT, and 280 out of big 3 patients required neurosurgical intervention. So as you can see, we can safely use this. The safety margin is very much higher when we are taking big 1, because only 4 patients required a HCT, and none of them required intervention, and none of them became sick or required ICU care or ICU management with them. However, 21 patients of 295, that is big 2 group, we had thought it was normal and we discharged or we had admitted without getting a CT. 21 required progression, required CT because of the clinical deterioration. So the conclusion which they did was, there was no traumatic brain injury related post-discharge emergency department visit or 30-day readmissions in big 1 and big 2. So there were completely no readmissions in big 1 and big 2 group, and all patients which required neurosurgical intervention were all from the big 3 group itself. So that's the conclusion what they concluded as, yes, we can use big guidelines for stratification for traumatic brain injury patients in ED. Now another article which was considered clinically relevant for critical care, that is, can we take a blood culture from arterial line? And how do we determine whether this culture from arterial line is contaminated when it's compared to a peripheral central line? So the study design again was a multi-center prospective study of 590 critically ill patients suspected with sepsis, out of which 1,655 episodes of blood culture from December 1821 was done, and the outcome which they measured was the proportion of contamination. So how did they determine this proportion of contamination? Were for each patient, whichever patients were included in the study, all of them had an arterial line placed within 5 days. So they have taken they took the culture from the arterial line simultaneously from a peripheral line, grew the cultures, and identified how many patients had contamination, how many patients actually did not have any cultures grown, and how many were false negative. So as you can see here, 2 patients in arterial line were proven to have contamination, 4 with vein function had contamination. 547 of arterial blood samples had 2 negative, and 545 had 2 negative again vein function. So it is almost the same when it have the arterial and the vein function. So they concluded telling that obtaining blood culture from arterial catheter is an acceptable alternative if the patient is having an arterial line within 5 days placed compared to a vein function in critically ill patients. Another last topic which I want to discuss today was, has EM lost its allure in US? So what happened in the last match in US was emergency medicine lost 555 unfilled positions. Almost like more than 200 or more than 300, more than 10% of positions were unfilled in US the last 2022 match, in 2023 match. So as we all know, emergency medicine specialty is considered really advancing. It's much more dynamic and recognized in US compared to India. So 26% of drop in applicants from 2021 to 2023. It is very alarming because in such a country of such wide horizon and such wide knowledge about emergency medicine, there is so much of drop in the applicants. So what is a paramedical in India? So as we all know, in India, emergency medicine is still in its infancy, and we are all striving hard to increase the increase the awareness in our juniors, increase the importance of emergency medicine in various hospitals. So how do we deal such things in India? It's an open-ended question for everyone. So how do we deal such parity in India? So how can we improve the knowledge, especially in our juniors? Because as we all know, we keep having interns, we keep having junior residents in our department. So we all have everyone has a thing that emergency medicine. Do you want emergency medicine? Oh, we'll just talk about it. So no one is actually, in the class of 150, if you see, at least 10 to 20 people will be interested in emergency medicine. Still they don't choose emergency medicine because of various other reasons. So how can we deal it is another question. And was this an effect of COVID pandemic is another question which leads us. So the answer to this question will only be taken. We'll get this answer only after seeing another 2-3 years of trend. But yeah, so this is what the present state in US. The next match is still awaited. So there I'll end my presentation by this quote. Emergency rooms were the nightmares your nightmares had while they slept there. So I just end with this note. Thank you so much.
Although we get abundance of knowledge from books, it is clinical trials and updated protocols that often guide us to come up with better treatment plans to ensure the best outcomes for our patients. Thank you, Dr. Vydehi, for that enlightening talk. I would now like to request the moderators, Dr. Sudhama and Dr. Brinda ma'am, to felicitate Dr. Vydehi. And also, if there are any questions that the moderators have regarding the talk, we would like them to kindly join us on stage.
That was an excellent presentation from Vydehi regarding the updates. I would like to add on 2 points to this. Number one is the advent of artificial intelligence. It's okay. The advent of artificial intelligence is also, commonly known as augmented intelligence, that has come a great way invaded into almost all the sectors of the healthcare. So that is one thing. And I think in the emergency scenario, triaging by the AI is the outcome of the whole scenario. And earlier with the subjective experience, the cases used to get under-triaged or over-triaged. With the AI, I think that could be sorted out. In many other ways also it is coming in a very big way. That is one thing I would like to highlight. And the second one is regarding the new biomarkers what we have now, where the suspected cases of sepsis can be detected very early. Like you have a P-sepsin and you have MR, adenomedicine and all those things. These are also coming in a big way, entering into the ED, where the suspected cases of sepsis can be detected as early as that. Any questions from the audience? Thank you, Dr. Thank you.
Requesting ma'am to felicitate Dr. Vydehi. have you on the stage, please. Thank you so much, Dr. Vydehi. I would now like to request our beloved HOD ma'am, Dr. Kalpana, to felicitate Dr. Sudha ma'am and Dr. Bruna ma'am for joining us today and giving us their valuable inputs and insights. We really appreciate it.
Thank you, ma'am. We have a next interesting topic, toxin-induced metabolic acidosis, differentiating the etiology in the ER. For this, we have an esteemed speaker, Dr. T.V. Ramakrishnan sir, Professor and HOD EMD, SRMC Chennai, to join us in this event. And we have Dr. Shakuntala Murthy ma'am, Professor and HOD EMD, St. George's Medical College Hospital, as a moderator for this talk. We have Dr. Jagadish sir, HOD of Forensic Medicine Department, Vydehi Institute of Medical Sciences, also as a moderator for this talk. We request Dr. Shakuntala ma'am and Dr. Jagadish sir to kindly take the dais.
A very good morning to all. Good morning. Thank you, Professor Kalpana, for this wonderful honor that you've given me. It's been a very pleasant stay and it rained yesterday night. So, Bangalore, I always envy people staying in Bangalore because I'm from Chennai, where we have only 3 seasons, hot, hotter and hottest. It's such a pleasure coming to Bangalore. This is a very abstract topic. I have spent many sleepless nights trying to read about it and things like that. So I'd be very happy if the audience could also participate in this. Toxin-induced metabolic acidosis, differentiating the etiology in the ER. Obviously, this metabolic acidosis that we encounter very frequently is a consequence of many toxins that the patient would have been exposed to. It can be quite challenging for the emergency physician on call to find out what is the reason for this metabolic acidosis. What are the possible causes of it? As you are treating the patient symptomatically, you need to find out what are the causes for this. And if the patient has a prolonged metabolic acidosis and you're not able to find a cause for this, obviously the cellular functions and all are, not proper. So the patient worsens and finally the patient dies. So it's very important that you recognize the problem at the earliest in treatment. This is the definition that everybody knows. Possibly in metabolic acidosis you have an increase in the acids, especially the hydrogen ions, and you have the bicarbonate which actually counters it. So anything that decreases the bicarbonate levels tells us that there is an increase in the acid load, and plus the patient also starts hyperventilating, trying to bring the pH back to normal. So what are the challenges that the emergency physician actually faces? Obviously these patients will be on altered mental status. Significant clues at the scene suggest that the nature of the poisoning may be absent, or they would not have really looked into it. may be overlooked by the person at the scene, could be not conveyed properly to the providers. And these patients might be brought by friends and not by the family members for them to give us a history as to what's the patient's medical condition previously. So there are a lot of problems. We have a lot of gaps are there in the information that the emergency physician actually seeks before he starts coming to a diagnosis. Metabolic derangements can cause an increased acid production, especially in alcoholic ketoacidosis, especially when you take ethanol. Metabolic derangements can happen. Acute starvation can cause ketoacidosis, especially when you have an alcohol binge and you do not eat and you have starvation ketoacidosis. Another thing that you can encounter is INH poisoning, where the patient actually comes with refractory seizures, elevated anion gap metabolic acidosis, and could be comatose. Again, this, I'm sure the youngsters know about how to calculate the anion gap. The only thing is, later on, initially the anion gap was around 12. But the improvement in science, and they were able to actually, the chloride levels that they could measure actually increase, and actually came down from 12 plus or minus 4 to 7 plus or minus 4. So that's what is the anion gap calculated these days. Nagma was one of my favorite actresses as I was in my 30s and 40s, so I can never forget Nagma. So this Nagma, I'm sure most of you know it. And it's called cat mud piles, especially carbon monoxide poisoning, cyanide poisoning. We don't see much of cyanide poisoning. I used to work in anesthesia earlier, and we used to do a lot of spine surgeries where we used sodium hydroxide, and that was the time when we saw some degree of toxicity with metabolic acidosis. But now I don't think we really encounter this. Yes, a lot of blue sniffers. Yes, toluene poisoning is possible. Methanol. Yes. So these are some of the poisons that you can encounter in the emergency department, salicylates. All these can cause high anion gap metabolic acidosis. So what's the way ahead? I do a blood gas, I find metabolic acidosis. What do? It's always A, B, C, D, and E. Take care of the airway, breathing. If the patient is in hypertension, find out what the reason for that is. Is the patient behind fluids? Do an ultrasound, check the IVC, give fluids. And once the IVC is nice and full and the patient's blood pressure is still low, he might need to be started on vasoconstrictors. So that is the way forward. Look for any special orders that you can find. Track marks, especially in case he's a drug abuser. Other physical examination clues, and of course the blood gas is the one that's very, very important. And a 28 ECG to look for any ECG abnormalities. A comprehensive metabolic panel, your electrolytes, your urea creatinine, all these things are very, very important as you try to come to a diagnosis. Quantitative tests are available, but again, it does take time. And some urine screening tests are also available, which is qualitative, which whether it just tells you whether it's present or not. But at the same time, I tell my residents, if you have used an opioid or if you have used a benzodiazepine for intubation and then you send the urine sample after half an hour, it's going to be positive anyway. So you need to keep that in mind when you send your urine samples. Again, studies have found that it's rarely beneficial. It's not all that useful doing these drug screens. So the best way is to assess the patient and keep reassessing these patients, whether the interventions that you have done for the patient is actually benefiting the patient or not. So a lot of clinical acumen is essential when you are dealing with such patients. How do you narrow the diagnosis, especially in high anion gap metabolic acidosis? Iron poisoning, GI symptoms, yes. You take an X-ray, you might find the iron tablets which are radio opaque. INH toxicity, this child can come or the person can come with seizures, refractory seizures, which benzodiazepines may not actually work in these patients, and these patients can be statusless. Yes. Methanol poisoning, usually with visual complaints. That's one of the first signs that the patient is probably having a methanol poisoning. Salicylate, they say it's a fruity odor. I have not actually seen that. When these findings are absent, what do? Lab analysis has to be relied on as follows. Begin with your serum electrolytes, bun, creatinine, and glucose. You take a CBG, if it's hyperglycemia, yes, you don't really have to worry, probably ketoacidosis, diabetic ketoacidosis. But at the same time, you can have a starvation ketoacidosis, your blood glucose can be normal also. The point of care creatinine, and nowadays you can get your creatinine levels within 5 or 10 minutes. You don't really have to send it to the lab and get it after 2 hours. If you find that it's elevated, possibly it could be an acute or chronic kidney failure. Do a urine dipstick for glucose and ketones. So all these things will actually give you some clue as to what is happening. Still, you're not able to diagnose much. Your sugars are normal, your urea creatinine is normal, your ketones are negative on the urine dipstick. What do you do now? The patient has severe metabolic acidosis. Start treating the patient. Give fluids. Hydrate the patient well. Give dextrose if necessary, thiamine if necessary. Try that. If your acidosis is improving, the etiology is either ketoacidosis or metabolic acidosis with hyperlactemia. Lactates are increased. What is the reason for the lactates to be increased? Methanol or ethylene glycol concentrations may have to be measured. So if all these things don't work, then think of alcohol intoxication. These are some of the important points that will help you in the diagnosing in patients with high metabolic acidosis. Ketoacidosis can be excluded if normal glycemia and the urine is negative for ketones. Lactic acidosis, obviously your blood gases give you your lactate levels, and if it's 2 or 3 or less than 3, then you can exclude that this patient does not has lactic acidosis. Renal failure, you do a point of care creatinine and you would know whether the patient is in renal failure or not. Patients with salicylate overdose could present with hyperventilation. That's because of the severity of metabolic acidosis. We are trying to increase our minute ventilation, trying to bring down the PCO2 and the pH, trying to increase the pH towards normal. They could have mental obtundation also. That could be a clue that it is possibly a salicylate ingestion. Methanol gets converted to formic acid and causes seen as depression, visual impairment, intoxication. Abdominal pain is common in methanol poisoning. Check the hospital gap. But do not delay therapy until the blood level is obtained. In case you think it's a methanol poisoning, start treating the patient with the antidotes, omeprazole at the earliest. Ethylene glycol, it actually gets metabolized into glycolic and oxalic acid, so the acid levels are actually increased in the blood, and patients are obviously intoxicated. But in ethylene glycol poisoning, the patient usually does not have visual disturbances, so that would help us actually differentiate between a methanol and an ethylene glycol poisoning. The osmolar gap, if you check, it's often normal in a patient with ethylene glycol. These are some of the drugs that actually cause elevated osmolar gap. And we are usually concerned with alcohols. We do not actually encounter the others frequently. What are the treatment considerations in this? Obviously, recognize the cause early and treat it. Provide excellent supportive care, like I told you earlier, including airway control and fluid resuscitation. These are the cornerstones for saving the patient. Sometimes the patient could have been on metformin, and just discontinuing the drug would actually help in improving the patient's condition and improving the metabolic acidosis. What is the role of buffer therapy? Again, very controversial. A lot of people use sodium bicarbonate for treating the acidosis. But there are a lot of problems when you use sodium bicarbonate. Again, one is the sodium load. Your patient's cardiovascular status isn't great, and you give some hypertonic solution that actually a lot of fluid shifts happen, your intravascular volume increases, your heart may not be able to take it. Hypokalemia is a possibility. If you use a lot of soda bicarbonate, your ODC shifts to the left, so the hemoglobin does not holds on to the oxygen much more, so your cells are starved for oxygen. So these are some of the problems that you can actually encounter when you do soda bicarbonate. But there is definitely a role, especially in salicylate poisoning, use of bicarbonate, where you want to alkalize the urine and eliminate the salicylate. or patients with sodium channel blockers, and you have changes in the ECG, and that is one of the actual indications for using soda bicarbonate. Let's look at the first case. This is a 34-year-old male who is a diabetic, brought to the emergency department comatose, unresponsive, GCSS 3, that prompted intubation and mechanical ventilation. Obviously, he is acidemia. His PCO2 is on the lesser side. He is hyperventilating. Bicarb is very low. Lactates are high. NM gap is increased. Your blood glucose is 150. What do you want to do next? Anybody? What do you want to do next? Come on, are you all acidotic? Are you all ethylene glycol intoxicated? Come on, guys. You want to look at the ketones? He wants to do a fluid resuscitation. Osmolar gap. Okay. Obviously, you want to do some baseline investigations. Urea, creatinine, electrolytes, serum osmolarity, excellent. Ethanol levels, arterial and venous blood gases. Again, you have to calculate the serum osmolarity, which is again 2 into sodium plus 1 by 2.8 plus glucose by 18. And if you have the levels of ethylene glycol or methanol, you can actually add it to the equation by subtracting it with the appropriate values. It's very difficult for me to remember, that's why I have it on the screen. Okay, but as exam-going postgraduates, I'm sure that you have to remember all these things. So how do you calculate the osmolar gap? It's the measured osmolarity minus the calculated osmolarity. Normal is usually less than 10. Presence of an abnormal solute that is present in significant amounts can actually increase the osmolar gap. If ethanol levels are measured, again, not many centers actually measure all these things. It may take 1 or 2 days also for you to get the results, so do not waste time doing that. This can be added to the calculated osmolarity. An osmolar gap of more than 10 to 25 milliosmoles with high anion gap metabolic acidosis is suggestive of a toxic alcohol condition. You have an AGMA plus your osmolar gap is more, that means it's possibility of a toxic alcohol condition. But again, the osmolar gap and the anion gap can change over time. Initially, there's a raised osmolar gap due to the presence of the parent compound, that is the toxic alcohol itself, and that's a solute actually which is increasing the osmolar gap initially. But as it gets metabolized into acids, you find that the osmolar gap is actually coming down, but the metabolic acidosis is actually increasing. So that's what happens later. So if you have a patient who comes to you later, the osmolar gap may be normal, but this patient can have high anion gap metabolic acidosis because of the breakdown of the alcohol into acids. Let's look at the second case. You have a 14-year-old boy. This is brought to the emergency room by a mother with history of dizziness, vomiting, syncope, and seizures. He is drowsy, his secretions are clear, he is able to maintain the airway. Again, acidotic, PCO2 is 43, probably there's some degree of respiratory acidosis also because it's not compensated adequately. Bicarb is low. Lactates are obviously increased. Blood sugars are around 136 normal. And seizures are persisting in spite of giving lorazepam. Any ideas what could be? Sorry?
Isoniazid.
Yes, possible, yes, definitely. Because I told you the two earlier, resistant to even benzodiazepines. Anion gap is increased. Mother gives a history of the boy being started on TB medications along with vitamin tablets. Seizures due to INH poisoning are often refractory to treatment with benzodiazepines and are difficult to manage without pyridoxine. So it's good that you start your pyridoxine earlier in these patients. 1 gram of pyridoxine for every 1 gram of INH that is being taken to a maximum of 5 grams and 70 milligram per kg in children up to a maximum of 5 grams. So concomitantly pyridoxine administration is very useful, and that is the one that would help this patient. Third case, you have a 61-year-old woman presented to the emergency department after awakening with left-sided weakness. No recent history of seizures. MRI, there was no evidence of an acute stroke. Following her arrival, she became acutely confused and complained of tinnitus, shortness of breath, and blurred vision. APGs, she is hyperventilating, obviously your PCO2 is low, so the pH is actually increased. Bicarb is hovering around 15, lactates are increased, blood glucose are 136, and your anion gap is 20. What do you think we are dealing with? Yes? Possible, yeah, it's very simple, right? I wish the patients come in like this, give us proper history, and it's so nice. It's actually a science-led poison. Usually does not happen like that. Yes, we are dealing with that. Gives a history of being unwell for the last 2 weeks with symptoms including persistent headache, which got relieved on taking aspirin. Suspect when there is an injection, obviously, of salicylates. Vomiting, tinnitus, tachypnea, respiratory alkalosis. This is the usual feature that the patient presents with. Obviously, you have an elevated anion gap metabolic acidosis. Accumulation of organic acids and all these things because of uncoupling of oxidative phosphorylation and keto acids with increased catabolism because you have hyperthermia also in these patients. This causes an elevated anion gap metabolic acidosis. So your patient presents like this, and in case the patient has tinnitus and things like that, your suspicion should be more towards salicylate toxicity, especially when you have a patient who presents with such severe metabolic acidosis. Case 4. A 30-year-old woman brought to the emergency department by family members in a drowsy, unresponsive state with profound muscle weakness after waking up in a closed room. APG acidotic, PCO2 is 42, not compensating, bicarb is 13 less, lactates are increased, your blood sugars are 136. Yes, that's a very simple one. What is it? Yeah, possibly a carbon monoxide poison. Yes. CNS, your patients can present like this with headache, nausea, dizziness, confusion. Do a mini mental status examination, and the patient makes errors, incoordination, ataxia, seizures later on, and finally the patient could also be comatose. So getting a good history is very important, especially during the winter months where they are in a closed room and they might have have a fire or something there, and things like that. Dysarrhythmias are quite possible in these patients. Obviously, ischemia, and these patients can either present with hyper or hypertension. Other symptoms are abdominal pain, diarrhea also, which is an unusual presentation. Patient can be dyspneic type chest pain and palpitations. It's very easy these days because the carbon monoxide levels are actually measured in the blood gas levels. Do you have that in your blood gases? Carbon monoxide levels? It's there in almost all the blood gases. So nowadays it's much easier that way. At the same time, you should realize that the partial pressure of oxygen there is not a problem with the partial pressure of oxygen because gas exchange does occur. There is no problem. The alveolar gas exchange occurs. Your plasma has a lot of oxygen. But the problem is because the hemoglobin is unable to carry enough oxygen. So that is where the problem is. And because the saturation that is calculated in your blood gas machine is not accurate. So you have to take the saturation on the monitor, which gives you a better idea about the hypoxia that's actually happening. Case 5. You have a 21-year-old male, listening and in a confused state. He is a painter by profession. On arrival, appears intoxicated, partially responsive to verbal commands. He is obviously acidotic. He's trying to compensate for it. Bicarbonate on the lower side. Lactates are increased, probably because of hypoxia. Blood glucose levels are normal. Anion gap is 12. So what's going on? He's a painter, man. Possibly sniffing. Low sniffing possible? Yes. Toluene is the compound that's usually there and can cause such metabolic acidosis. These are some of the symptoms that the patient can present with: mood swings, can have nausea, vomiting, anorexia, can present with wheeze, headache. So these are all given in the standard textbook, but get a proper history so that you will be able to actually come to a diagnosis. So toluene exposure is it's an acidic metabolite, called butyric acid. That's what it gets metabolized into, which causes the high anion gap metabolic acidosis. This is in acute. But in a chronic abuse of toluene, because these are all going to affect the kidneys, can cause damage to the kidneys, and distal renal tubular acidosis can actually occur. And during this time, you may not have the high anion gap metabolic acidosis, but your anion gap can be actually normal in chronic exposure to these drugs. So keep that in mind. So what's the take-home message to my talk? Diagnosis of a toxic ingestion should be actively investigated in a patient with a high anion gap metabolic acidosis, where a diagnosis of ketoacidosis or lactic acidosis or renal failure is not apparent. That means your urine ketones are normal, the lactates are normal, your urea creatinine is normal, but the patient is not persistently in metabolic acidosis. Then you please get a proper history and have a suspicion that the patient could probably have a toxic exposure. Thank you all for your patience here.
Thank you, sir, for that delightful talk. Treating acid-base disorders without knowing the exact cause of derangement is like putting a flimsy band-aid on a hemorrhaging wound. Hence, it is so important to clench the diagnosis, and I'm sure after Sir's talk, we will all be able to treat metabolic acidosis in poisoning cases better.
Thank you, sir, for a very valuable and informative talk regarding this toxin-induced metabolic acidosis. And we ask the moderators if there are any questions to sir.
Thank you, Dr. Ramakrishnan. That was an excellent talk, and I also thought the topic was quite difficult, but you have simplified it quite a lot for the delegates. Thank you. And I don't think I have anything to add except that, yes, as you said in the take home, that when you don't find any other obvious cause. It so happened that we recently had a patient exactly like this with, we thought it was alcohol intoxication, but he came and the blood alcohol level was quite low. So he had consumed alcohol, and then we found a severe metabolic acidosis and the osmolar cap was high. So considered methanol, and he was treated, ultimately he was dialyzed and he did it out. So thinking of the cause, so this patient came with a GCS of 3 and with dilated unreactive pupils. So if we had not thought about a cause, he might have been considered brain dead, and treatment might have even been discontinued. So very important to look for the cause. Thank you again. Okay.
Sir, with your vast clinical experience, in fact, thinking of the topic, so you have simplified it in such a easy way that I think everybody would make a diagnosis. Anything more to that. Thank you.
Thank you, ma'am, for sharing your experiences with the patient. And
so there's such a case where the exact toxin is not known, a suspected case of toxin. When do we submit these patients for hemodialysis? What is the role of hemodialysis here? Can we take them earlier for hemodialysis so that your acid settled as early as possible?
Absolutely, I think that's a valid point. If the patient's metabolic acidosis is not being corrected, and you don't have a clue as to what it is, dialysis does have an important part in persistent metabolic acidosis. Again, before the patient becomes very hemodynamically unstable, I think you have to take it up, because once the patient becomes hemodynamically unstable, the dialysis also has its own limitations.
So I think we can go ahead and
Absolutely.
the suspicion is not ready for.
Absolutely, ma'am.
Thank you.
I think she has a question.
It's a very informative talk about drug-induced metabolic acidosis. Adding on to that, there are certain antiretroviral agents which can also contribute to lactic acidosis, because currently we have 2 HIV positive patients in the main medical ward, and we are planning to go ahead with antiretroviral therapy. One patient is already with Stephen Johnson's. The other patient is with a non-healing ulcer. So in such patients, when they are already into sepsis and we are treating them with multiple antibiotics, plus when we add on antiretroviral therapy contributing to lactic acidosis, how do we categorize them and how do we distinguish? That is first question, sir. Second question is even linezolid is one antibiotic which can contribute to metabolic acidosis. What is your opinion?
I don't think there's any way that we can prevent giving these drugs to them. You have to start, I mean, that is also one of these things, antiretrovirals causing such metabolic acidosis. Yes, I want to put that as a case study and I thought for lack of time I will do that, yes. But I guess you have to start that and watch these patients carefully. At least you know what the problem is. You don't really, you know what's the causative agent then. Maybe you have to stop it or come down on the dose and things like that. I don't think I can think of anything else. Anything, Dr. Shakul?
So also the certain drug interactions like ketoconazole and heparin, could that also cause metabolic acidosis with drug interactions like COX inhibitors and beta blockers? Could that also we need to keep a watch when it comes to lactic acidosis or metabolic acidosis?
Absolutely, I think that can also, anything that decreases the metabolism of one, so the availability is much more there in the bloodstream. Yes, I agree. I think that's the reason why you must, person from pharmacology actually making rounds with us and telling us, are we giving the proper dose of the drugs? Are there drug interactions that are actually happening?
Yes, yes.
I think they have a very important role for that and they should help the clinicians in actually doing it.
Thank you, Meenakshi ma'am and Prima ma'am to add to this discussion. Now I request Dr. Jagdish and Dr. Shakuntala ma'am to kindly felicitate the round question. On the desk. Thank you, ma'am. Thank you, sir. Sir, I request you to kindly stay on the seat. I request Dr. Durga Prasad to kindly come and felicitate our moderators, Dr. Jagdish and Dr. Shakuntala ma'am. Dr. Durga Prasad, sir. Thank you, everyone.
Ladies and gentlemen, as we wait for the chief guest to arrive and for the inauguration ceremony to start, I would like to bring to your attention that we are going to have a couple of fun events planned for today and tomorrow. We'll be having an EM quiz, an EM jam, and a clinical pathological case presentation, which has involved 15 different medical colleges, case presentations from 15 different ones where the staff have sent their cases and the postgraduates will be deciphering them. So the EM quiz Phillips is open right now, like the spot registration is open right now and will be today afternoon. And the EM jam with the clinical pathological case presentations will be tomorrow. I request participation from everyone present over here and it will be a very fun event. As we wait for inauguration, we would like you could take your time out and like register for the events, please. Can everyone take this seat, please?
As we wait for our chief guest, why don't we make this event a little more interactive? I would like some of you to share your best experiences with us. What was that one case or that one patient who changed your mind and your approach to your clinical practice? We would like to pass the mic around. If anybody has anything to say or would like to share some of their best experiences, please feel free to do so.
request the delegates to share their very brief experiences with that one patient who have changed the perspective of how you would have been treating patients henceforth. I request Dr. Mehta ma'am to just share small experiences in our ICU with her.
Mike was suddenly handed over to me. Not to work for it actually. Yeah, we've come across a lot of patients whom we have given a good outcome and also would have suddenly thought what else we could have done to make this patient better. Maybe, yeah, we had a patient who came in with snake bite actually. He was a young male who came in with snake bite. And initially he was having a very bad cellulitis lower limb for which the vegetative compartment syndrome for which a physiotomy was done and we could get him out of that, but unfortunately he went into severe acute kidney injury. That happened and the dialysis was done. Then hemolytic uremic syndrome. One after the other was happening. Good morning, sir.
Sorry to cut you short, ma'am. We'll definitely hear to you again. We will now proceed with the inauguration of the event. I'm sure we feel a certain higher power guiding us through stressful situations, not only at work, but life in general. Being in such a grueling profession, it becomes impossible to sustain ourselves without the endurance bestowed upon us by God. So on this very special occasion, let us take a moment to acknowledge that and invoke the Lord's divine blessings. I now call upon Navya and Aditi, undergraduate students with us, to deliver the invocation song and fill the room with their melodious voices. Navya and Aditi, can we please have you on stage?
गुणशरीराय गुणमण्डिताय गणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमट्टाय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थाय गुरुविक्रमाय गुरुप्रवराय गुरवे गुणगुरवे गुरुदैवतदंशक्त्यै गुणधर्मसराय गुरुपुत्रपरितात्मय गुरुवाकण्ठकण्ठाय गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि.
Thank you boys for the delightful recital. Requesting other dignitaries to occupy the seats on the dais now. I will request our chairperson, our beloved Dr. Kalpija Madam, please brief our inauguration with a few words.
Requesting all the dignitaries to occupy their seats on the dais now. That is. Ladies and gentlemen, now for the moment we all have been waiting for. May we have a huge round of applause as I take immense pride and pleasure in inviting our chief guest, Chief Dinesh Gunduraj sir, Honorable Minister of Health and Family Welfare, Karnataka. I would also like to welcome our guest of honor, Dr. Kantara ma'am, our beloved chairperson ma'am, our exemplary advisor sir, our respected principal sir, medical superintendent, our chief administrative officer, and last but not the least, the powerhouse for this entire event together, Dr. Kalpana ma'am, HOD and Professor of Emergency Medicine, Vydehi Institute of Medical Sciences. Now requesting Dr. Kalpana ma'am to deliver the welcome address and introduce our chief guest and guest of honor.
Thank you, Dr. Vibha and Dr. Chimay for the wonderful introduction. A very good morning all to the dignitaries on and off the dais. As quoted by Albert Einstein, education is not the learning of facts, but the training of the mind to think. Today is one such great opportunity in this third annual state level conference of emergency medicine, that is EMK Karnataka 2023, organized by the Department of Emergency Medicine, Vydehi Institute of Medical Sciences and Research. On behalf of the entire organizing committee of EMK 2023, it gives me immense pleasure to welcome the august gathering on this pleasant morning here today. At the outset, I would reminisce our beloved founder chairman, the great visionary leader, Dr. D. Aditya sir and Mrs. Satyabhama ma'am for having prophesied their dreams and guiding each one of us to achieve more in life. To continue with the similar legacy, it's an honor that we have amongst us today our dynamic leader, Srimati Kalpana ma'am, Honorable Chairperson by the Group of Institutions. Ma'am, your visionary leadership, resilience, is the base of challenges, and your unwavering commitment to healthcare are truly commendable. Your charismatic leadership is an example of excellence and dedication, which serves as an inspiration to countless others who look up to you as a role model. We welcome you, ma'am. Ladies and gentlemen, put your hands together as we welcome our distinguished chief guest, Sri Dinesh Gunduraj sir, Honorable Minister of Health and Family Welfare. Born into a family of political legacy, he pursued an engineering degree in electronics and communications from BMS College of Engineering, Basangudi, where his academic excellence and civic engagement were evident. Mr. Dinesh Gunduraj sir's journey in the Karnataka State Youth Congress began in 1994 rising to the position of president in 1998, showcasing his unwavering dedication to public service. In just 6 years, he was nominated to contest assembly elections in the Gandhinagar constituency, Bengaluru, capturing hearts and with his simplicity and concern for marginalized communities. His election to the Karnataka Legislative Assembly in 1999 marked the beginning of an impressive streak of victories, earning him the title of the undefeated Sardar. His integrity and commitment to the Congress party remain unquestionable. As the cabinet minister responsible for food, civils and consumer affairs, he successfully implemented the Annabhagya program aimed at making Karnataka hunger-free despite facing criticism. His tireless advocacy for healthcare, education and women's empowerment. We are fortunate to have such dedicated leaders working for the progress and prosperity of our state and nation. His commitment to the Congress party and his efforts to improve healthcare in the state make him an exceptional figure. Your presence here today is a testament to your support for academic excellence and your commitment to the growth of our state's healthcare facilities. We welcome you, sir. As we embark on this journey of learning and growth, it is imperative that we have a guiding light, someone whose wisdom and experience has helped us navigate the complexities of the medical profession. We are truly honored to welcome University of Health Sciences, former Director of Medical Education, Karnataka, former Principal of Bangalore Medical College, former member of ad hoc committee of MCA appointed by Honorable Supreme Court, the former Dean, Director and Advisor of our own Vincent RC. Her dedication to medical education and patient care is exemplary, and we are truly blessed to have you here, ma'am. Throughout her tenure as our advisor, she has demonstrated not only remarkable expertise, but also a deep-seated passion for nurturing the next generation of medical professionals. We are deeply honored to welcome you, ma'am. I would like to extend a warm welcome to Dr. Mahesh Kottapalli sir, our beloved advisor, Vincent RC, who is also an infectious disease specialist based in DeSoto, Texas, under whose wise counsel and visionary insights our medical culture has witnessed academic excellence. He is deeply invested in nurturing a culture of research, empathy, and community engagement among our faculty and students, ensuring that our institution remains at the forefront of medical advancements. We welcome you, sir. Respected Principal Dr. Sridhar Venkate, sir. Chairman Dr. Fayaz Ahmed Sattar, sir. Medical Superintendent Dr. Uma Maheshwar, sir. Chief Administrative Officer Dr. Ravi Babu, sir. Under whose leadership our medical institute has consistently scaled new heights of academic progress and innovation. I would like to extend my deepest gratitude to all our esteemed speakers here for gracing us with your presence. Indeed, Dr. T.V. Ramakrishnan, sir, from Sri Ramachandra Medical College, Chennai. Dr. Ashima Sharma, ma'am, Nizam Institute of Medical Sciences, Hyderabad. Dr. Durga Prasad Reddy, sir, Chief of Vydehi Institute of Cardiac Sciences. Dr. P.K. Shishma, sir, renowned cardiologist of our own Vydehi Super Specialty Hospital. Dr. Shakuntala, ma'am, one of the pioneers of emergency medicine. Your support and encouragement inspire us to strive for compassion and excellence. I would also like to extend a warm and heartfelt welcome to my dear Vydehi family who have gathered here today. Emergency medicine is a field that is constantly evolving and demands continuous learning and collaboration. This conference is a unique opportunity for all of us to expand our horizons, gain knowledge that will undoubtedly improve the quality of emergency healthcare delivery. Over the course of this conference, we have curated various programs featuring keynote speakers, panel discussions, hands-on workshops and presentations from experts in various facets of emergency medicine. These sessions will offer valuable insights, share best practice, and stimulate thought-provoking discussions on the pressing issues in our field. We are honored to have such distinguished faculty and diverse group of enthusiastic delegates from all over India who have gathered here today on this magnificent day for our academic feast in emergency medicine. Welcome you all. I encourage each one of you to actively participate in the discussions and seize the opportunity to learn and grow. I am confident that the knowledge and insights gained here will help us in providing better patient care. Let us be reminded that our collective mission is to heal, to innovate, and to uplift. Welcome to EM Karnataka 2023. Thank you all.
Thank you, ma'am, for that illustrious introduction of our distinguished guests today. Asitama Sadgamaya, Tamasoma Jyotirgamaya, Mrityama Amritam Gamaya, Om Shanti Shanti Shanti, which literally translates to lead me from the untruth to the truth, lead me from darkness to light, lead me from death to immortality. I now request the dignitaries to kindly lead us from the darkness of ignorance to the light of knowledge and wisdom by lighting the lamp. deep gratitude to all the esteemed dignitaries for gracing this occasion and lighting the lamp. Now requesting our deeply loved and revered chairperson, Mrs. Kalpija Ma'am, to address the gathering.
Very good morning to all of you. My profound, humble pronouns to our founder chairperson and chairman, Dr. D.K. Adikeshwaru. Before I start, we as Vydehi are extremely happy to organize this conference. As you can see, first and foremost, I am deeply humbled and thankful for our Honorable Minister of Health and Family Affairs, Dr. Dinesh Gunduraji, to have graced this occasion and taken this precious time out to be here. This is a very important conference for emergency medicine, as we call it, because it's an emerging field in India. And this is where the most outlook and approach and also the awareness has to be created, and it is a very honorable day for us that you have chosen to be here and grace this occasion. And as you can see, this is a very young department, very young. They have got third. We are only 3 years into the state conferences. So I wish you all so much of success that we scale up to new heights and see more people engage in emergency services. And I thank our first advisor, Dr. Kanta, for being here today. It's been a lucky day. She was supposed to be there day before yesterday for a hospital day. She has chosen to grace this emergency medicine day. Ma'am, deeply humbled. And as usual, our advisor, Dr. Mahesh Kotapalli, have somehow he 145 days, and this to be here at this time is very special to us. Thank you for being here, and our principals of all the colleges, our medical superintendent and everybody, thank you for making this a success. I want to see the emerging field of emergency medicine to go scaling, because COVID taught us what is emergency medicine. It taught us new learning lessons. We at Vydehi were very, very complacent, I would say, very honestly, because emergency medicine was just like where we used to feel trauma coming, just they would treat and they would go to their ICUs and operation theaters. That was not that. They were the face of an hospital. I realized they were the face of an hospital, which was so important. And if you can see, the first thing our advisor said was, we need to change the outlook of emergency medicine. And if you see, we have a brand new emergency medicine, and very proud to say that no corporate hospitals in Bengaluru would have a emergency medicine like that. We are very proud to have presented it with their own bed set of 24 beds, and you should see the kind of thing we have uplifted our emergency medicine, and nothing more a better opportunity than having a state level conferences. And I wish to have more all India level of emergency medicine, critical care coming into this area, so that we can provide and improve the services of trauma and emergency. Something like COVID was an awakening for everybody, and I think every bit of it the government could do. As private sectors, we should pitch in to do the best, so that we move forward and share our knowledge for better prospects of our future Bharat and India. Thank you so much, sir. Again, I will not keep you for long, and I would leave it to everybody and wishing this conference a big success. Thank you all.
Thank you, ma'am, for your ever-inspiring and encouraging words. I'm sure that it has had a deep impact on every single person seated here. I'd now like to request our remarkable advisor, sir, Dr. Mahesh Kotapalli, to address the gathering.
Good morning. First of all, thank you all for being here, and I would like to again thank the Honorable Health Minister for gracing his presence here. So you have elevated this conference to the next level with your presence. Thank you very much for coming. As you're all aware, that ma'am already told, the first thing anyone enters into a hospital, it says emergency room. That's where everybody goes. they go to OPDs, but if they have real problem, that's the first thing you want to see. So when someone comes to the place, they don't know what level of trauma center that the hospital has. How many of you are aware of the levels of trauma here? Just one person. How many of you are aware of what level trauma is for the emergency room? You work here, so you can answer. We are level 1. Level 1 trauma center is the highest level you can have for a trauma center. Entire Whitefield and I think another 5-6 kilometers beyond Whitefield, south of it, there's no other trauma center that is level 1. Level 5 is your standard little gully clinic. They can put a band-aid and give you a shot. That's level 1. Level 5 is where everything can be done. So we have level 1. So we're extremely proud to have that. And not a lot of places have that, and we also spend considerable amount of time and funds to develop this trauma center in a welcoming place. If you go to the usual emergency room, it's very chaotic, ugly looking, people get scared, but that's not what a trauma center should look like. It should be welcoming, clean, neat, welcoming. And as soon as a patient comes in, the first thing they have to see is a physician over there with a compassionate, approach, and not crowd that patient with your PTs and interns, 10 people crowding the patient, and they're scared. What the hell? I come here for something and I'm being seen by 10 different people. That's not how it should be. It should be a team. It's called triage. First you triage the patient, see where the patient fits in, take the patient there, an appropriate doctor goes and sees the patient, stabilizes, make sure the patient is stable. You remember the ABCD? Airway, breathing, circulation. ABCDs are important. You stabilize the patient. If they need airway, you secure the airway. Make sure the blood pressures are good, pulse is good. Then you look at everything else. So these are the things that we want to instill in our students here. And fortunately, we were able to do that across the way. And I don't know if a lot of people know that this is the first medical college in Karnataka to start the emergency medicine program 13 years ago. And when we wanted to open another hospital in the city center, we were looking for emergency doctors. I was really surprised that not a lot of people are trained in that. We're getting anesthesiologists, we're getting critical care guys, but not purely emergency trained physicians were available in the state. It's very surprising. And hopefully more and more younger people would go into this route because it's very fulfilling. Academically, it's very satisfying. Economically, it's very satisfying. There's a high demand for doctors over there. And hopefully we'll all implement these protocols that are coming up across the world. For example, you have your acute MI protocol. How many of you are aware of acute MI protocol here? Acute MI protocol, 30 minutes from door entry to cath lab. As soon as the patient comes in, you see an ST elevation, you only have 30 minutes. 30 minutes, the patient should be in the cath lab, and we're proud to say that we do implement it over here. So that's one of the major achievements. The second one is the neuro protocol. You guys are aware of that? 3-hour period. You have a window of 3 hours. God knows how many when the stroke happened, but if you can find out within 3 hours, you give the thrombolytics, there's a good chance this patient will survive. And having high trauma level care in your neighborhoods is very important. Every hospital should have, at least in the cities, at least they should have a level 3 or 2, 3. But teaching hospitals like this are all level 1. And also, we noticed a lot of, improper training that we witnessed causing a lot of mortality during COVID. Because a lot of people didn't know what to do, when to do, how to intubate, how to stabilize, how to isolate. A lot of people don't even know how to look at the case properly to see if it's an MDR coming from another hospital. For example, you have a patient in another nursing home. They keep them for 5-10 days, do everything, finally they say, go to a bigger hospital. And the patient comes in, without realizing, we go approach the patient, and don't realize that this patient is just coming from a different hospital, carrying with them a multi-drug resistant bacteria, and he is entering into our premises. And we are naively going and touching this patient without proper clothing and everything, and put that patient along with the other patients. And before you know, within 5 minutes, that bacteria is spread from patient to patient to patient, and that patient is moved to the ICU, and the whole ICU gets spread like wildfire, contaminated with multi-drug resistant bacteria. So emergency doctors should also be aware of where this patient is coming from. Is he coming from home? Is he coming from another nursing home or from another hospital? As soon as you know or realize that this patient is coming from a different hospital, your first priority is isolation. You put that patient away from everybody else, isolate them, treat them, stabilize them, call the appropriate consultants, do your imaging, whatever you have to, but don't mix that patient with the rest of the patients because you want to spread that infection like wildfire. That is the most important mistake I've seen happening in emergency departments. So every emergency department should have an isolation area where the patient is kept away from the other patients until we make sure that this patient is not carrying a multi-drug resistant bacteria. Especially intubated patient, tracheostomy patients, patients with catheters, patients with wounds. These are the patients you have to be very, very, very careful and isolate them. So hopefully you will learn a lot during this conference, and I also want you to go and spend some time in FASA, our simulation academy over there next door. Learn, take time, see how many intubations can you do, how many central lines can you do, how are you going to use the ultrasound to use central lines. You have everything. So please make use of this facility, and I sincerely welcome you all to this conference, and I hope you take home some good things out of this. Good luck.
Thank you so much, sir, for that motivating talk. Like you rightly said, we couldn't be prouder of our emergency department here at Vydehi. And we are ever grateful to you as an institution, sir. Thank you so much. Next, I'm deeply honored and highly privileged to call upon our respected Health Minister, Shri Dinesh Gururao, sir, to address the gathering.
It gives me great pleasure to be here at this conference on emergency medicine, and I want to thank Mrs. Karnataka for having given me the opportunity to come over here and to see this wonderful facility. I was really impressed by what they're doing and the kind of approach that they had. Also, Dr. Mahesh, who just spoke so well on this very important subject. Dr. Kanta was here, a renowned person in medicine in Karnataka, and all the other dignitaries on the dais, and all the participants of this conference, and all the other doctors and administrators of this institute. Emergency medicine is something which, like the term itself suggests, it's a very critical part of healthcare, and to have and to be able to provide good emergency facilities, emergency care, and trauma care is of utmost importance because it is not only just doing the procedures right, but also to be able to do it in as quick a manner as possible with rapid decision making. I think that becomes the key. And how you can, in that short period, take the right decisions and execute things in the right manner. So, definitely, it's something which can actually, some people lose their lives because of the illness. Here, I think, not only because of the illness, but also to be able to to be able to allow all of you to hear and listen and interact with experts, with brilliant people who are in this field, who know this field, and who you can interact with and collaborate with and understand things better. And that will make you, not only in terms of knowledge, will your knowledge get enhanced, but also your skill gets enhanced. The skill also is very important in this. So I think the sector is such that Mrs. That there is a paucity of people in emergency care, and we find it difficult to get good people. You also just mentioned that we are not able to get good people. So I think we need more people, and the more we expose people to this, the more we make our students aware of this. I think they'll get attracted to being part of emergency medicine and critical care and being part of trauma care. So I'm sure that this conference will take us in that direction. And ultimately, the way to go forward is to grow. And how do you grow? You grow by engaging, you grow by discussing, you grow by being able to interact and understand and asking questions and explaining your point of view. So that is the most important aspect of a conference, is that we're able to discuss and evolve and create, maybe while you're doing something, you get better ideas. And even for the people who are training you or who are coming and speaking in the conference, when they are talking to you and when they are being questioned by you, that also makes them think, and they also get enhanced in how we can improve the way things are functioning. So I'm sure that this conference will be a great success, and I also want to thank the Vydehi School of Medicine for this wonderful infrastructure that they've set up over here. I think it is brilliant what they've done over here, and I think it's adding great value to our health services and health research. I think that is something which we need to also give importance and priority to. And of course, I did visit the simulation center that they made, and I was quite blown away by the way it has been wonderfully done, beautifully designed, and I don't think, at least in Karnataka, nobody has got this. I don't know about India. Nobody in India also, so that's fantastic. Because it was really top of the line, and it was so interesting, and it was, I think the students and doctors, it gives them so much opportunity to enhance their skills by working in the simulation in that place, because you can learn without really getting worried if you're making a mistake or if you're doing something wrong, because it is something that you can keep practicing there. And the setup is so beautiful, and it is like recreating the actual hospital and the environment of an hospital. So, and emergency care, they set up an ambulance and how you can take them out and how you when to intubate, all those things, and defibrillators, all those. So it's, I think I should thank you for inviting me to this program. So thank you very much, and wish this conference all the best, and I hope all of you will learn a great deal, and that will enhance your skills and your abilities and your knowledge, and that ultimately will serve society, because every doctor or every health professional, if he can improve his service, that is a great contribution to the state, because health is something which is important to a state. Health is a core subject for any state or any government, because that's one of the core areas where when you look at human development, what is the state of education, what is the state of health, how are the people being treated, and what are the healthcare facilities. And these are the things which actually really change the society. And to be a developed country and to be on top, we need to have our human development to be really at a very high level. And for that, health and education becomes the two main components. An educated individual and a healthy individual becomes an asset for the country, becomes an asset for the nation. And our intention always is to, ultimately for us, for India, our biggest asset is our human resource. We have so much of human resource. So if we can convert every human resource into an asset, then I think there's nothing to stop us. We will become the most powerful nation in the world. Because we have the ability, we have our culture, we have our history, we have our knowledge, and everything is there. The thing is how we can enable our people, how we can develop them, develop their, whatever qualities that they have, and to be able to strengthen those qualities that they have, and to be able for them to fulfill their own capacities. Many of us cannot reach where we want to reach because we don't have the requisite training or the requisite support system to achieve to our own potential what we can achieve. So for that, health and education becomes key, and I think the more we develop in terms of health, the better care that we can give, the stronger, greater our country also becomes. So I wish you all the very best, and thank you very much.
Thank you so much, sir, for the empowering talk and the kind words that you've had for us. We are highly obliged to have you with us today, elevating this occasion. I would now like to call upon the highly accomplished Dr. Kanta ma'am to take over the stage and address the gathering.
Salutations to our late Dr. Adikeshwaru, but for him, we would not have assembled here. So let us salute the great soul. Friends, the most healthy, I should say, and also young and energetic Minister of Health, as I emerged out from this Karnataka, first time I think. We are grateful to that. Definitely this healthy minister and health minister will do a lot, particularly to this department. Because emergency medicine, we started like a kindergarten school children in the beginning, very small, to get trained people. And we had to train, and I should say at that stage, Kalpaja helped us a lot to improve because we lost our chairman by that time, not able to meet the ends. She was struggling a lot, but even then she took a bold steps in establishing this department. And I just a little contribution, getting a medical man, getting him a training and making him as a professor of emergency medicine. This I could do because I was in Medical Council of India, where even this department is very insensate, not developed. It is not very easy to say that this department is very easy to develop and we can do wonders. Yeah, name is very, very nice. All the troubles, Dr. Mahesh knows how difficult it is. At that stage, just like a kindergarten child, we developed it. I think I should thank Dr. Murali Mohan, who was with me at that time. We had to go to different places to find out how to establish this department. Yes, we did it, but not as our satisfaction. This satisfaction comes when a doctor who is in charge of the emergency medicine is really a human, having all the qualities of a human qualities like gratitude, forgiveness, love. If it is not there, I think it is difficult to establish the department. Here the patient who comes there is definitely almost at the tail end of the stage his life, he may be there. And he has to attend to the patient. Not only that, his attenders, we had a very tough time. At that time, our own intern was manhandled by the village people here nearby, and some problem was there. Okay, it was clear. So the doctor who is in charge has to face all this music. So he must be ready to face everything. So he must have all the human qualities. And with that quality, with the help of a team, it is not individual. Emergency medicine is not an individual department. Please understand. It is a collective department. Everyone must join together. It is a syndicate. Then only the department will flourish. Of course, the most important is Dr. Mahesh's department. Infection. Gone. Once the dead body will be sending out. So that has to be controlled. It is very difficult, particularly in Indian standard, particularly in rural folk setup. Now all these can be managed, provided the management uses enough finance. Very little to earn, but a lot to spend in this department. I think most of you will agree with me. You cannot count. The patient comes there without money. But what will you do? He is dying, you have to treat. Now that's why I request our health minister, who is so energetic, definitely he will do. The government hospitals to have, it has to be upgraded into an emergency medicine department, and the doctors can be sent, for example, even to Vydehi to have a training for a few days. No one is perfect in this. I am sure no one is perfect in the emergency medicine unless until he is really a human being. With these few words, I thank and congratulate Mahesh and Karnataka for having been inside. And now everything is on the shoulder of our young, energetic and passionate minister. Let us call him as Dr. Dinesh Bindu Rao.
Thank you so much now for throwing light on the ER department's history at Vydehi. It was truly wonderful to know about that. We would now like to request the audience to kindly rise up as we felicitate our respectable health minister. A small gesture for our end to pay our tributes and convey the deep admiration that we hold for him. We would now like to felicitate our beloved Dr. Santana. So honored to have you here today with us. We'd like to extend our deepest gratitude and thank all the dignitaries present here today, especially the Health Minister, Shri Dinesh Gururao sir, for giving his valuable time to this event and gracing this occasion in spite of his busy schedule. Thank you so much, sir, for being with us today.
As for a photo session.
Wow, that was a sight to behold indeed. Let's proceed with the program again. I'm deeply grateful to all the guests present here. Thank you so much. Thank you. Let's proceed with the program and the rest of the events starting today. Requesting Vydehi to introduce the next speakers.
Moving on and going back to the scientific talk sessions. Now we have Dr. Ashima Sharma, Professor and President of Emergency Department of NIMS, Hyderabad, to give a talk. And also I request all delegates to kindly be seated. I now take this time to welcome Dr. Suresh Korpala, Professor HOD of Urology Department, RIMS and RC, and also Dr. Girish Narayan, Professor of St. John's Medical College, to be the moderators for this scientific talk. Thank you.
Just one request, the posters and the papers timings have been put on the WhatsApp group. Please come to the area only when what your timing has been allotted to you. If not, please stay here, attend the sessions. Come to the posters and podium presentation only at the time that has been allotted to you.
We have invited the chairpersons.
Hello. Hello everyone. And a very good morning to all my colleagues. I'm here, I'm Dr. Ashima. I'm Professor and Head of Emergency Medicine and Exams. And I know many of you, and many of you know me. Okay, I thank my chairpersons. I think your all should be started. I love the way they are taking the photo selfie out there. I don't wish to be a part of it. Okay, so let us talk in some language of stroke when I want to extend my gratitude to the Department of Emergency Medicine and Vydehi. The amount of trials, the names of those trials which are part of the talk today, the thing that we call recent advances, was enormous. And I could not escape reading late early up to the dawn. So what I do, I try to be swift in to bring the prime trials to your attention. I hope you all understood what I'm going to talk about. So these are all trials which we will be discussing and try to get it clear how it would be to manage acute ischemic stroke reaching the emergency department in today's world. I'm sorry I'm not standing there. Short in height, I won't be seen. I'm too photo conscious. Okay? Statistics. Any busy day in your emergency, in my emergency, well, 7 to 8 stroke cases definitely coming every day, isn't it? When we have varied presentations, they may come with absolute symptoms, clinical symptomatology which says, yes, this is stroke and nothing else. They can come with symptoms mimicking stroke, which we call stroke-like symptoms. They can also come with recurrent episodes of stroke, or they can come with some issues regarding to their airway and breathing, coming from other hospitals where they have been diagnosed and have been managed partially for their petition. Well, in this particular disease pathology, the evaluation and intervention goes hand in hand, especially when we are talking of window period. Well, we are going to discuss what window period is all about. Okay? How many of these patients are really reaching to the stroke capable centers? Well, if I'm not wrong and you guys are with me, I'm trying to talk of those centers where there is a possibility to do neuroradiology. There are neurointensivists, there are neurophysicians, and then most importantly, emergency department, who will be the ones who will recognize these patients and put them on the pathway of early reperfusion strategy. Well, there is still a lot with in these statistics which can be talked about for public awareness. People at homes recognizing that this is stroke and reaching the hospital early. There is a lot of things where you need to have community reach programs as well. Okay, so the window is 3 hours, the window is 4.5 hours. The window can be, as I come from the land of ECAS 4, up to 6 to 9 hours. Oh, I'm so sorry. And the windows can be up to 24 hours as we are going timeless with our new strategy. Well, let us talk about the first recent advance in the management of stroke. I call it ambulance number 1. How many of us have seen that it is very important for the pre-hospital emergency services to early recognize, initiate right treatment, notify the right hospital, take the patient to the right hospital? Well, this is all very important, isn't it? So we have the technology of mobile telemedicine, we have the technology of integration of CT scanners at point of care laboratories, in the ambulances, and not only this, we do also have reasonably accurate, which are most important, firstly placed, reasonably accurate stroke identification algorithms. Well, this is what a good ambulance would look like if it is called as a mobile ambulance for stroke. It would have inbuilt CT scanner, and this is all what is happening in Western world. In few of the societies, this is a photograph which has been taken from a French stroke unit, mobile stroke unit, and I am sure sooner or later we are also reaching over there, where we can do teleradiology, neuroimaging in the ambulance only. And more so, it is very important. Just look into this bar graph. It is very important to understand that the time the paramedics pick the patient to the time the paramedics bring the patient to a stroke capable center, there is a lot they can do. And that has improved the outcome of these patients. If you see the second one, the moment they realized and did us first aid and included them into the study, and this is where the magnesium sulfate, which was used as a neuroprotective agent, infusion was started. The third one, this is called the freezing concept. The freezing concept is when we start neuroprotection right in the ambulance. That society has gone one step ahead. They have gone into a step called as ambulisis. That means initiation of, obviously after a scan which has been done in the ambulance itself, radiology, the neurointensivist being contacted on mobiles, and permission sought for initiation of a loading dose of the agent for intravenous thrombolysis, and that is the policy which they follow for ambulisis. This is what is the future we are looking for. There is a lot of potential into it. It will definitely reduce the time for DPA initiation treatment. It will definitely have a neuroprotective role for the patient. There would be a lot of patients where these patients would be early routed to endovascular therapy, because the paramedics will fill the chart, tick out the potential, tick out the parameters with potential for potential endovascular therapy rather than intravenous thrombolysis. Comprehensive notification to pre-notification to the centers will go. Golden hour trials in acute stroke will come out and improve, and there will be an improved and continuous stroke awareness happening. Nothing is achieved without some disadvantages, or I would say some teething problems when it starts. and therefore it would also have some leading problems. There has to be a revamping of present stroke algorithms. There would be some issues which are more of technology related while we are transferring that data. There has to be improvement in what we call internet services and yet sufficient by intravenous thrombolysis in less than 60 minutes, that is within 1 hour. What is important here is involving the stroke or neurology team in less than 15 minutes. Okay? So that is very, very important. Putting a hand on my heart, I can say my job is only to recognize, supervise, stabilize, send for scans, making sure this patient does not have increase in his present issues of disease issues, related issues. Do an NIHSS scoring. Talking to the attendants, very, very important point was given just now, that communication is very important. You know, the son is running from his office. He would like to know what kind of stroke it is. And all of us know that with a simple score you can guide him that it is a mild, moderate, severe or a very severe stroke. So this is my job. Yes, to early reperfuse, decide on reperfusion, my job. But then to give, I would definitely involve my neurophysician, my neurologist before they, and look out for them to take this particular decision, because it is always a teamwork. There is no fun in doing it by yourself and then later having issues. Going ahead. No, it is, you may say, oh, if we thrombolize so fast, have you thrombolized a stroke mimic? I'm not going to go into the list of 15, you can read it. I only put it because when we ask in exam what are stroke mimics, most of the students stop at 5 or 6. So let us see what is the evidence is now. The evidence comes from some 10,000 plus patients, okay? And this, they said in this stroke registry, SITS, that only 429 were the mimics, that is about 4.1%. There are only 2 reasons why light goes off in between. I myself is very enlightening. Or maybe it doesn't love me. Thank you. So, okay, so if we do this thrombolysis for a stroke mimic, are we doing something which is incorrect? Well, incorrect in the sense whether there would be higher chances of a ICH. Well, no, they did not find it. They did it for 10,000 patients. They did 4%, 400 were stroke mimics. So it might be possible. It is not 100% proof that you may by chance have thrombolized a stroke mimic, but it will not cause increased incidence of intracerebral hemorrhage. And I'm not putting it from my experience, I'm putting it from a 10,000 patient registry done at an international level. Okay, now the evidence moves on. Please tell me about 30 minutes also. So the evidence moves on. There is a need. Will this gentleman, 66 years old, fit into my criteria or absolute contraindications, relative contraindications of giving IVT? So I have to know that. So this is what my history should be for a stroke patient. This is what an examiner looks out for a stroke patient when you give history. That whether you have, there is no fun of telling me that he had a tuberculosis or not, and was he treated for ATT when he was 22 years old. Not bothered. No. But I am bothered, or each one of us should be bothered, if we do not know whether he had or did not have these absolute contraindications. So just to revise with you, there is something which should not have happened within last 21 days. Some upper GI bleed, some, okay, something which should not have happened the last 90 days. So a stroke, a head trauma. So these are the ways you should remember to keep them in tips. Now you can always come back to me and say, very difficult, the list is long and exhausting. Stick it to your wall, give it to your paramedics, give it to your youngsters. Anything, that is the rule. You do it for some number of 25 by 110. The fact that there is a fever which is pointing out toward infective endocarditis. There is something called as symptoms which are proving that it is more of aortic dissection and an embolic stroke going on. Okay, well, active acute breathing diastasis. So this not happened 21 days back, but 30 days back he had an upper GI bleed or a genitourinary bleed. Same may present in the hematological studies, a platelet count less than 1 lakh, INR more than 1.7, more than 40 of APTT, and whether he is using a therapeutic dose, not the prophylactic dose, a therapeutic dose of agents, anticoagulants, which are low molecular weight heparin for conditions other than this stroke, like DVTs, ACS, and all that stuff. Well, these are all relative. Do not bother about them. Except for aortic dissection. Yes, I will start your and you know, we have focus. We know how to diagnose aortic dissection. Isn't it? One yes. No? No yes? We don't know how to diagnose aortic dissection? We do. So, if that is this, do not start it. Other than that, start the IVT and just look out for these blood tests to come. If they come and come on a negative side, you can always stop it. You can give platelet transfusions, you can give FMPs, you can give cryos based on which investigation has come out to be abnormal. Well, I go further. I have said that it is the physical exam in a stroke case, while you are put him in the scanner and while he's undergoing a scan should not be about anything else than understanding the severity of strokes. That is very, very important. Also because there is a need for a particular NIHS score for which you do your reperfusion strategies. Okay? I don't know, I have put them on, but I don't want you to, you should know the entire NIHS score. If you are going for exam, you should know if you are managing a emergency department. And the beauty of this is there is 1 to 4. If the total score is 1 to 4, then it is a minor stroke. If it is 5 to 15, it is moderate. 16 to 20 is a moderate to severe stroke, and more than 21 to 42, which is the highest number, total number which one can have, is about severe stroke. Well, I have finally understood the severity of the stroke. I have understood that whether he had some relative or absolute contraindications with the history. If I still have some time, which this gentleman is giving me because he reached very well before 3 hours, then there is no difficult problem that I take by another sweet 2 or 3 minutes to rule out these history points, which are about fever, which can be pointing towards infective endocarditis. It could be other infections, especially when they sepsis where thrombotic strokes are a common headache, which can be a prodrome before a thrombotic stroke, or it can be a hemorrhagic stroke altogether. Vomitings, again, more common in hemorrhagic strokes, and also in posterior circulation. The whole acute ischemic stroke, which is being talked, is about anterior circulation. Is that so? Are we not thinking of posterior circulation ischemia? We are, and that is what we will soon understand. Decreased level of consciousness, yes, again, it would be about hemorrhagic stroke, and if there is a decreased level of consciousness without focal neurological these are not the newer recent advances, but these are the facts which you ignore while doing it. So I thought this is the right moment to talk about you. And now, in the meantime, my patient's diffusion has come. What can I see here? I can see a okay, I'll only speak. Do I see a issue of ischemic zone on diffusion MRI? Yes or no? Please help me out. Yes, thank you. Do I see an apparent diffusion coefficient? Is there reversal of ADC on the next scan? Yes. This tells me about the acute illness of stroke, about the salvageable tissue. Well, I had MRI next to my ER, I went ahead and did. You have CT, go ahead and do that. So it is not hard and fast to do. This is more for the strokes where you do not know the last normal time. Okay, some idea about whenever this reversal is there, it is not always because of the cytotoxic edema of stroke. It can also be because of abscess, acute demyelination and inflammation. This is very important because that is when you may have issues, dilemmas of diagnosis. And who helps you when there are dilemmas of diagnosis? To me, my neurologist helps. And I'm sure working as a team, you will also have the same. Well, if I would have taken this patient for a CT scanner at a time interval between 3 to 4 hours, there is a possibility. And that, in a registry it was told that those who develop early CT signs do not have a good outcome if you do IV thrombolysis. Well, this is more of a neurologist who would probably tell, but the registry says we should not worry about it. Go ahead and thrombolyze. They are early infarct changes, which have been mentioned over here: loss of gray-white differentiation, insular obscuration of sylvian fissure, loss of insular ribbon, and cortical attenuation and sulcal effacement. Now, those eyes of neuroradiologists, which are trained to read that, will also tell you, seeing this particular scan only, what is the core infarct and how much is the penumbra, which is the salvageable part. Because anything which is focal swelling can be 66 years old, well in window period, showing us acute infarct on diffusion MRI. We have also seen if he would have been taken to CT, what would have been what would it show like, and also we have understood his NIHS score. We have done a physical examination to rule out neck injury. We have checked his history to understand what are that. We have ruled out fever, we have ruled out infective endocarditis, and also ruled out aortic dissection. Okay, so we are ready. This very slide talks about those minor and disabling strokes. Dr. Vivek mentioned them in the morning in one of his studies. See, whatever is disabling, even if it is an NIHS score of 3 to 5, okay, go ahead and thrombolyze it. We are thinking that this is a minor stroke, but for him, it can be a severe aphasia, it can be a complete hemianopia, it can be extinction, visual or sensory, or any weakness where he cannot sustain lift against gravity, and so on and so forth. Remember that these all are relative contraindications only. All throughout this, I had not talked about ruling out doing the blood sugar, because I was thinking someone would probably check, give me an sort of a hint that blood glucose, which is a strong mimic, though I have mentioned it as a mimic, has not been checked. What if the sugars are 50 milligram per deciliter? Give glucose and go ahead and thrombolyze. Just because he is hypoglycemic, we cannot stop him from Okay, the topic is at the bottom somehow. These are the additional warnings. Would he have come between 3 to 4.5 hours? If his age is more than 80, I would have been a little worried, not absolutely worried. I would weigh the benefit and risk ratio. If he has a recurrent stroke, I would have been a little worried, especially if there is a diabetes mellitus. And also if his INR values are very disturbed because he is on oral anticoagulants. Well, should we now, with all this in our mind, please give me a yes or no. Should we go ahead and thrombolyze this patient? Please, I request you all, yes or no. This gentleman, 66 years, do you want to thrombolyze him or not? If the team is not with me, how will I go forward, please? I just have 5 minutes. Time is gone. Okay, so I'll only say that yes, I will thrombolyze if the blood pressures are, but I have to ensure that the blood pressure is less than 180 by 105 before and up to 24 hours. The drugs which I use for controlling the blood pressure which this gentleman has is labetalol, 10 to 20 milligrams IV, which has to be given over 1 minute, and then after 2 minutes you can use a second dose. I do not use nicardipine or clomidipine. If you use nicardipine, clomidipine, absolutely wonderful drugs. Sodium nitroprusside is another second line drug if you are not able to take care of the blood pressures, and but remember it has a little issues with the platelet count, and it is known to increase intracranial pressure. So use your friends to help you out. Okay. Yes, we always need to correct the blood pressures before going in for this. We have two options. We have either antiplace, we have or tenecteplase. Doses are, I know you know the dose. Okay. Both of them agents. Which is the best one nowadays, which is preferred in Western world also, is tenecteplase. Why? Because it is one time you have to give, single injection followed by a saline flush. Okay, a small study in Japan said no, not 0.9 milligram per kg of antiplace. Go ahead and do 0.6 milligram per kg of antiplace. Very small study. I will look out for further evidences before I can really present it out to you from the podium. Yes, the dose of tenecteplase, 0.25 milligram per kg, maximum dose of 25 milligram single dose. Okay? Yes? Give me just 5 minutes more because we need to delve into aspect scoring for understanding the patient has a salvageable penumbra or not. We are still not done with it. So you all know Alberta scoring, CT scoring for anterior circulation, posterior circulation. It is also there. It is, remember the aspect score. The lesser the score is, it is better or it is worse. I don't see emergency physicians out there. No. Thank you so much. It just helps me to stop. So what we are doing is, when we are looking for mechanical thrombectomies for wake-up strokes, for unknown last periods, what we are doing is to look out for mismatch. This is what is diffusion flare mismatch. Diffusion positive, flare negative. This is diffusion perfusion mismatch. You can see that the green area is telling you about the penumbra, whereas the red dot is telling you about the core. The core is very small. This is again one of the study where perfusion weighted image is seen over a diffusion weighted image, and it shows that the upper and lower ones are different. The upper one has a large core where larger ischemia, whereas the lower one has a smaller core. So why this all core volumes? Core volumes are important evaluate him for IVT, start evaluating for mechanical thrombectomy as well. There are umpteen number of studies where patients will directly go for mechanical thrombectomies. IVTs do have issue of angioedema. I'm sure a few of you must have seen a 6 to 7% chances of ICH, and there can be a lot of other systemic bleeds also. But it is important for a patient to restore the blood flow in cases of ischemia. Okay, we have talked about it. Indications in anterior stroke, yes, CT angios you have to do a CT angio, and I'll show you an angio to understand it and the aspects of more than 3. Modified Rankin score and TICI are important scales. It should be in your ED because that is what you compare. Whether you compare at 90 days, yes, and for the TICI immediately after thrombectomy, but to talk in scientific language, you have to tell where did your patient reach after your intervention. Okay? The whole stories which I was telling has just this implication that if you are adding MT after an IVT, then if you are choosing 100 patients, 20 at 90 days would be 0 to 1 of modified Rankin, 40 will be 2 to 3, whereas on one patient would still be will be not good, that is at a MRS of 4 to 5, and 3 may develop new infarct because of the intervention of MT after IVT. This is very important to understand, but if you choose right from start MT, especially on patients where IVT had absolute contraindications, like then the numbers are same, but the ones who have developed new infarct or the ones who had poor outcome of a 4 to 5 modified Rankin score, but the numbers have improved for those who have become functionally independent at the end. Well, this is the aspects for posterior circulation stroke. Now I will rush through it. I've already gone through entire stuff many times. Harmis trial has meta-analyzed the entire trials which showed benefit of MT within 6 hours, says yes for it. Aurora study has meta-analyzed the entire benefit of MT from 6 to 24 hours. It also says yes for it. Remember, there is not much significant incidences of spontaneous ICH occurring in either of these meta-analysis. Okay, this is something which came in Neurology Journal. This is about in February 2023. It is the busiest slide I have, and I have to read it that for patients in acute ischemic stroke, the recommendation is intra-arterial MT mechanical thrombectomy, whether or not the patient has received treatment with IVT or if the conditions are met. And this is a grade 1B recommendation. The brain imaging using CT without contrast or DWI excludes hemorrhage and is consistent with the aspect score of more than equal to 3. The CT angio or the MR angio demonstrates a proximal large artery occlusion in the anterior circulation as the cause of ischemic stroke. The patient has a persistent potentially disabling effect, that is an NIHS score more than 6, and the patient can start treatment treatment can be started, that is a femoral puncture can be done within 24 hours of last well-known C. This recommendation applies when thrombectomy is performed at a stroke center with appropriate expertise in the use of endovascular therapy. Benefit may be most likely when imaging confirms the presence of salvageable brain tissue as in Dawn or Diffuse 3 trial. Okay, I'll use this. I'm sorry. Okay, the first one up shows this is another lady who has come to us. The first one above shows this 46 years old lady coming with a diffusion flare mismatch. Can you see the first 4 ones? It shows a diffusion flare mismatch. She was thrombolized. CTA was done next. Still M1 portion of camera and code, then why do we have to stop at 24 hours? And that is probably why director plays after 24 hours timeless trial is going on. I thank you all for your patient listening, and I thank my chairpersons for
Thank you so much, ma'am, for that very insightful talk. Stroke is one of the most common cases that we see in the ED.
What's your experience between active plays and character plays? Which are you using more often nowadays? Evidence guidelines will say active plays, but character plays we talk about a lot.
Okay, so I would say that the choice of this agent changed from antiplace to director place with the change of headship of philology department. So it was antiplace before. I hope none of their student is here, otherwise I don't. So yes, but it is director place now, sir.
I'll just come in just on the private sector. I think you are in exams, which is probably state government funded or central funded. See here, patient has to pay everything except for the air and water. So therefore, what happens is that connective is a cheaper one, which still costs around 35,000 rupees. So by the time every patient is getting the money, often we cross the window period. So that plays a big role in for organizing the stuff. So because RT place is almost double that of this connect place. And secondly, the RT place is imported. It's manufactured by a German company, and this is manufactured by an Indian company. So there are certain other factors, which play an important role, especially in the private sector where patient has to pay for it. Thank you for your comprehensive talk.
Thank you so much. I do agree because it is 90,000 versus 30,000, and so one has to keep some amount in the emergency, and we get a lot of people who donate and all that stuff. So yes, sir, everything has teething problems. We also have those problems, but then at this forum, I thought to ignite the young brains to the possibility of using director place also.
Thank you, sir, for adding your contribution into this session. I request Giri sir and Suresh sir to kindly felicitate Chima ma'am. I request Dr. Kalpana ma'am to kindly felicitate our moderators.
Thank you, sir. Thank you, ma'am. We now have a small announcement for the delegates.
The delegates taking part in the poster and paper presentations, Dr. Rakesh Kumar, Dr. Amrish, Dr. Yurva Nikuleti, Dr. Krishnamurthy, Dr. Snehansi Patel, Dr. Mona, and Dr. Abhay Prakash can make their way to the lobby for the poster presentation. And Dr. Krishnamurthy, Dr. Yashaswini, Dr. Yash, Dr. Mamata and Dr. Sharon are requested to enter the conference hall 2 for their podium presentation.
Moving on, I hope you all had a chance to refresh yourselves. We will keep the event going with our upcoming session, the panel discussion. As I mentioned during our introduction, I am from an anesthesiology background, while Dr. Chinmay is from EMK. We often discuss cases and see how much we have in common, and yet how our perspectives and approaches are so different from each other, which is mostly shaped by the environment that we work in.
So we are really excited for this upcoming discussion, topic of which is intubating special population, an emergency physician, intensivist, and anesthesiologist perspective. For that we have our speakers, Dr. Harish Malapura, Director of Critical Care and Medicine, and Dr. Karthik Varun Bhairapa, Associate Professor EMD KIMS Hospital, Dr. Sunita, Professor and HOD KC General Hospital, Bangalore. And for this panel discussion, we have a moderator, Dr. Hariprasad KV, Assistant Professor, Department of Emergency Medicine, Jamia Medical College. We welcome them to the dais.
May we have a huge round of applause for all our esteemed guests tonight.
Good afternoon. Preparation prevents poor performance. Area management is the cornerstone of resuscitation. At the risk of sounding crass, if you don't manage the airway, the patient dies. There are numerous tools and models which assist us in protecting a difficult airway. But as you all have learned in the hard way, one-size-fits-all approach does not work. Especially in certain patient groups and situations where a combination of anatomical, physiological, and logistical challenges can be overwhelming for the emergency medicine physician. Today, let us shed some light in this domain, and I cannot think of a better panel of experts to do this. I once again welcome and thank our lead panelists. Consider an 80-year-old man presenting to the ED. Mechanism of injury is fall from 2 flights of stairs. When you do the primary survey, you see that the airway is compromised, patient is snoring. However, there are no facial injuries, but C-spine injuries highly likelihood, so you're worried. You do the assessment and you find that the patient is almost bradycardic, high blood pressure, everything suggests pushing reflex, irrespiratory distress with tachypnea, 36 seconds per minute, hypoxia, 90% saturation, and hypoglycemia as well. You correct the hypoglycemia, it continues to be the same. The issue of cervical spine injury, even though you do the manual inline stabilization, is a cornerstone managing the polymer operation. While seemingly protecting cervical spine, it poses significant challenges to the area operator. Dr. Karthik, do tell us, in this scenario, what should one consider and what critical steps and changes to RSI are to be done?
Thanks. So, intubating the patient, so this patient fell down from the stairs either it could be because of hypoglycemia related or it could be because of gas related or is sustained
in injury, that is secondary cervical cord injury. So coming to the critical steps, so most important thing is there are no best practice guidelines that are available in the literature. What is the best method and who should intubate this? So the most important thing is, so there is no right device as per the literature, and the most important thing is there should be the right person to intubate. And the person who is intubating and the device, whatever they are comfortable with, whatever they are using in the regular practice and their expertise, they should use the device whatever they are comfortable with. So, and some critical steps that are changed during intubation is, so definitely we will not do hectic or change during intubation. We will go with the jaw flush during pre-oxygenation, and while intubation, that is while laryngoscopy. So somebody either from the front or next to the person who is intubating, they will immobilize the head. That is, they will keep the both hands at the level of the ears, and the most important thing is they should not allow the head to be extended. And one more critical step is, and the person who is doing this manual inline stabilization, we call it as a Mills technique. So they should not restrict the manual, because already there is a is doing manual inline stabilization. The person who is intubating cannot extend the head. So we cannot get the oropharyngeal and laryngeal axis in one plane. So definitely this should be considered as a difficult airway. But if you simultaneously restrict the mandible, you cannot manipulate the airway. If you release the pressure on the mandible, you can anteriorly lift the mandible. At least there is some rule. So next. So intubation methods coming to either lower laryngoscopy or direct laryngoscopy. So it all depends on the person who is experienced to it. But if the patient is not critically ill, if it is an isolated C-spine injury and there is a time to take the patient to the operation theatre, so it's best fiber optic intubation is best suited to a controlled environment. But again for this, and the patient should be very cooperative for this technique. But if the patient is critically ill and he requires intubation, so RSI is the best preferred method with pre-oxidation and manual inline stabilization during intubation, and then either we can do direct laryngoscopy or video laryngoscopy. In video laryngoscopy there are CMAC and hyperangulated devices. It is best if hyperangulated device technique and if they have adequate experience with that. And most important thing, if you are able to see the cords, they can directly go with the intubation. So most commonly with the direct laryngoscope, it will be grade 3 or grade 4. So if you are unable to see, either they can use the Bougie method to assist the intubation, or they can do the burp technique. That will also help with the visualizing the cords, or they can intubate. But if you are not comfortable with any of this technique, they are unable to see. So what literature says is they can go directly, they should have a low threshold to do hypothyroidectomy. But now there is no experience for the person who is doing this and there is no help. So the next best strategy is they should not worry about the degree of extension of the neck. So the person who is doing a manual inline stabilization, they can release the head. The person can extend the head and they can directly go and intubate the patient. Why? Because hypoxia is dangerous to the brain and it causes more harm. And one more important thing is, in the literature, there is no evidence for this manual inline stabilization of the neck. So whatever the data they have, it's from the poor retrospective studies or from the cadavers, and nobody recommends it, but still our ADLs and so many trauma guidance recommend, so we have to use it. But if you are unable to intubate, you can release the neck and you can intubate, because hypoxia is very dangerous.
Hello. We all know that we don't get a controlled environment in the emergency department. It is entirely different from the anesthesia department. So when you are not expert, and when you the patient has to be done with the cervical spine sterilization, the second generation LMAs come very handy and they can decompress the stomach also, and you will be able to ventilate till the expert arises. An expert comes, or you make a controlled environment. You can buy time to make a controlled environment and go ahead with intubation. This thought should be there with us to proceed
and she's tuberous, labored breathing, and has poor bilateral air entry. As you get a blood gas and you're assessing the vitals, you'll see that the blood gas tells you that the patient has acute respiratory acidosis, and this needs intervention immediately. The heart rate is 100, blood pressure is high, seemingly because of the high carbon dioxide. The respiratory rate is not very reassuring with that level of carbon dioxide. The SpO2 is not that much of a concern for you immediately. She's doing well with oxygen alone. But the concern for you is the breathing pattern. Again, in this patient, apart from the obvious anatomical challenges, there are significant changes to the respiratory mechanics because of her obesity. Dr. Harish, in your rich experience in critical care, do tell us what are the caveats, what are our considerations, and what are the critical steps what we should take when we are faced with such a patient.
Good morning, all. So when it comes to dealing with the area of the obese patient, we need a proper thorough preparation in terms of assessment and in terms of intervention report. Because if you see the data, so in the general pool also, around 30% of the patient are having a BMI of more than 30. And if you consider proper obese which land up in the emergency department who require some sort of further admission, it's going to be around 50-55% among these categories of patients. So when it comes to obesity, so there are their own challenges. One, anatomical restriction. Other than that, their comorbid conditions what they are having, and their physiological acute insult for which they got admitted. Suppose when a patient came to the market obese, the main challenge is how we are going to take them under care. So for intubation, there is a biggest challenge getting attached to the monitor, the regular BP curve. If you are monitoring with the non-invasive method, it is not possible. So again, in terms of difficulties in airway, so most of the time we have a very obese chubby. So we have data suggest that whenever we are having an extra presence of more than 40 to 43, it directly correlates with the difficult airway. So small moves, and their tongue is swollen, and they are having a chubby tissue which is going to have a gravity dependent effect, and they have some sort of already complicated carrying of the airway. So when we are going to do minimal anesthetic agent also, it will collapse and again further worsen the scenario. Along with the chest wall, we don't have a sufficient place for doing some sort of airway intervention. So they have restricted neck mobility. So along with that, they are already having some sort of obstructive pneumonia, obviously hypoventilation syndrome, which have impact in terms of the right heart failure. That is one thing which we need to consider. They might be already having a high pulmonary artery pressure because of chronic hypoxia, pulmonary vascular resistance is high, afterload is high for the right side of the heart. So they are more prone for acute decompensated right heart failure. So we know that both left and right work in interventricular interdependent phase. So when you have an acute cardiopulmonary scenario with the background of the acute need of emergency airway and all, so that will impact on the cardiac output. So it becomes a vicious cycle kind of thing. So other than this, the existing comorbidities, they are obese, they fit into the syndromics, okay, they might be diabetic. So they are while you are giving oxygen to your NIV, so put them on nasal cannula. So now we have nasal cannula which we can do up to 60 meters per minute. So which literally breakdowns their microelectric. If the animal is sort of the low of the collapse, a small level collapse which helps in breaking those microelectric. And that again gives an additional 1.5 minute of safety period to sustain the hypoxia. So there are some of the proven techniques, and when it comes to proper intubation technology, selection, having like intubating bougie, video endoscope ready, and most common advice is whichever you are comfortable. On routinely you are comfortable in here that digit you need to try first. And give some kind of airway anesthesia agent. You can inject some sort of like spray local anesthetic agent. Choosing an agent is very, very important because they have some sort of altered pharmacodynamics and pharmacodynamics. Because their protein content is different, their lipid content is different. So choosing an anesthetic agent which should not be very highly lipid soluble. Problem is because of the high lipid solubility which had an impact on the redistribution of those things. So that we need to take care. Maybe you can like use ketamine. Okay, so short-acting muscle relaxing, if at all required assistance going on with your that should be your option. Keep all smallest of the smallest endotracheal tube ready. Because I don't think like performing ectoplasmy is very easy in these kind of patients. Okay, so it is a nightmare. If you learn cannot intubate, cannot ventilate scenario, like very, very difficult. First, they will desaturate badly. You are not able to open even in front of the neck approach. Very, very difficult. So they will deep incision if at all you are considering some sort of ectoplasmy. So along with all these airway manipulation, we need to take care of their systemic illness, like for what they feel. So they might present with rheumatoid pneumonia, all these things. They were already having a compromised thing, and to add on rapidly desaturating, they might be in sepsis. So that all those things we need to take care. It is not like we need an entire village to manage critically ill obese patient who require an emergency education as compared to elective operation. So these things we need to take into consideration.
Thank you, Dr. H for taking us through the extensive caveats which are related to this situation. Next, we have a 26-year-old lady who is in the emergency. She is primary graduate. She is 34-week. She presents in this department with fever and cough for 5 days, worsening wheeze and breathlessness for the last 2 days. As you see her, you see that she is gravid, seemingly term, severe respiratory distress, patient has labored breathing, bilateral bronchi, and poor air-entry basally. The blood gas is not reassuring. She is in type 1 respiratory failure and some element of the metabolic acidosis as well. She is tachycardic, tachypneic, and very severely hypoxic, and your non-rebreathing mass doesn't do justice. We're able to reach about 88%. Now, this is a nightmare scenario for anyone. A term pregnancy poses both anatomical and physiological challenges, and more importantly, the drug dosing and distribution is quite confusing for any area operator. So, I request Dr. Sunita, please give us a quick overview in managing airway in pregnancy in general and specifically this patient.
Pregnant patients come with a lot of challenges because of the reasons like because of the progesterone induced increased vascularity. You touch the tongue, they may start bleeding. This is one thing. And secondly, the enlarged breasts come in the form of hindrance for the scooping. So many of the times you have to use a short handle, not the blade, short handle has to be required. And how many of emergency departments are equipped with all these things? So we should put an effort to equip ourselves with all these things. And coming to this patient, when you have a type 1 respiratory failure, it is hypoxia. So it is better that though it has been told in the case study that they didn't use the non-invasive part of it. Type 1, even oxygen is so beautiful, you can use supplemental oxygen and bring back the oxygen saturation to normal, which you can never do with the carbon dioxide. Doing the carbon dioxide requires only the ventilation. So the fact that this patient has gone into metabolic acidosis, which is of course hypoxia induced, indicates that, and she is not being treated with the non-invasive requires a support in the form of intubation. So whenever we need to intubate a pregnant patient, it is always challenging even in the theatre. And as I have already told you, theatre is a controlled environment. You are taking the elective case, you are ready to intubate the patient in a controlled environment, you have a using agent and you have the nasal relaxant. When a patient comes in the casualty, you may not have the luxury of all these things, but still you have to intubate the patient. That is why I consider intubation in the emergency department as more challenging when compared to intubation in the theatre. These particular patients, the intubation is always resisted by the patient. Unless the patient is totally out, it is resisted by the patient. So what drugs can be used which will help us to relax, and then it will facilitate the intubation without hypertension, without tachycardia, without rise in the intracranial tension. So we should have a protocol what we can use. I usually prefer 0.25 mg of ketamine mixed with the 0.25 mg per kg of ketamine mixed with a small dose of propofol, maybe 0.5 mg per kg of propofol. If you give that, you do the SCOPE. When you do the SCOPE, you will realize whether you are able to see the cards. If you are able to see the cards and put it in fine. If you feel too much of movement of local cards is there, you are not able to intubate, you can that time use a short-acting nasal relaxant in the form of scoring. And please be prepared with various other equipments which are available to us. For example, maybe video laryngoscope. And I prefer video laryngoscope, any other kind of the scope used on normal patients to get the hang of that equipment. Don't use the equipment for the first time in a complicated case. And you should be knowing with which equipment I am very comfortable. I routinely intubate with the metal blade. Not that I use the metal hinge, but instead of putting the scope 2 times, I put the scope once. If required, I use the metal. If not required, I don't use the metal. Like that, each one of you should develop your own method. You want to have a bougie along with you, or you want to have this kind of scope or video laryngoscope. And it is, you have to put the tube is the ultimate. To do that, you have to align the 3 axes. Pharyngeal axis, laryngeal axis and oral axis. How am I going to do that? All the literature that is available to you is to guide you. You can do in a different method and can place the tube in the picture, it is nothing like that. So we have to develop protocols based on our own system. As I have already told you, it is always possible to use second generation LMS. Supraglottic airway devices, but interference in the stomach also, you can ventilate the patient also, and you can buy time and then you can plan for an intubation.
Thank you, ma'am. It was quite helpful. Moving on. An 80-year-old boy presents to the emergency department with sudden puffiness of the face, change in voice, lightheadedness and rash while eating at a restaurant. As you do the pediatric assessment triangle, you see that the child is pink and edematous all over. There is some change in the voice. You hear audible wheeze. Child is drowsy and slightly irritable. There is increased volume of breathing and you see urticaria. And the mother tells you that the child was known allergic to nuts and while eating they may have consumed nuts. The child is tachycardic, hypotensive, but yeah, the CRFT is over 3 seconds, well compensated. Tachypnic, because there is some hypoxia as well. The blood sugar is 90 mg per deciliter. As the anaphylaxis is being managed with adrenaline, you will also notice that the airway is threatened. In my opinion, the most dangerous of them all is the one that's rapidly changing, what we call a dynamic airway. This calls for a team-based approach with multiple safety nets. I would urge Dr. Warren to take us through this case scenario.
So, as you see the case, the clinical history you see, obviously, as the case, the patient, the boy is in respiratory distress. So, he is in tachypnea, he is having airway issues, and second thing is hypotension. So, given by the history, so any patient coming with airway mind is whether it's a histamine derived airway edema or non-histamine derived airway edema. This history is very important for us. So we tell that we don't have much time for the history taking, but this history is very important because the treatment management also changes based on this. So here the ladies had consumed some nuts and follow that she started having airway edema. So most likely it has to be a histamine derived airway edema. So that is why history is important, because your treatment management is changing, because now you have a dynamic airway. So the rapidity with which the airway compromise occurs is very quickly. So when it's a histamine issue and you have a patient having airway edema, it's almost similar with the anaphylaxis. So you have to treat on the same basis of anaphylaxis. So that's how we derived that this patient is a histamine related issue. And now how I'm going to manage this patient's airway. So obviously a preparation is very important in this patient. So this preparation patient is already showing what are the indications for me to intubate this patient. Patient is in respiratory distress, hypotension, tachycardia, and very importantly, you see the mucous membrane, the lips is swollen. So the patient is going into an impending respiratory issues. So if you don't intervene now, you will have a lot of issues and you really want to intubate this patient. So first thing is electrically tube this patient. So that should be a primary goal for this patient. So in your preparation, you have to get ready for intubation. And important things in your intubation you want to keep ready is the size of the tubes. You can't go with the regular size tubes in this patient. You don't know, he's having an airway edema already. So imagine the edema what is there in his larynx, in his pharynx. So you have to go with tube size the smaller. This size in this patient can go with 4, 4.5. So these are things you have to get ready. LMA here not recommendable because patient already has a laryngeal edema, and by chance you insert an LMA, getting the LMA out will be difficult for you, and patient you might lose the patient also by aspiration. So that should be there in your trolley, but that should not be an immediate thing. But very important thing you have to get ready is this patient is already in stridor. So you can't be in a situation where you cannot intubate, cannot ventilate situation. So you have to get ready with circulatory therapy. So you have to have a circulatory therapy set, and I'm telling you it's very difficult to do, as Dr. Harish was telling, it's not that easy, yes, because this baby is already in stridor, you can't make the baby, the pediatric patient to lie flat, you won't lie down, so you will have to use some form of anesthetic agents. So all these things are very important in your preparation. And when you come to your pre-oxygenation, very important thing is how you pre-oxygenate these patients. They don't lie down flat. So very important step is you can utilize your HFNC in this patient. So utilize HFNC. By chance you are in a setup, you don't have an HFNC, at least use your NRVM mask. NRVM mask with a nasal cannula. So you will be using both things. You use a nasal cannula as well as an NRVM mask. So these are the things where you have to do some changes in your pre-oxygenation. And intubation, yes, I told you it's very difficult. So if there is a patient here, is giving you some time, then you can go with your routine intubation. You can obviously you have to treat the cause or the precipitating factor. Here it looks like more of a histamine derived edema, so you will have to give antihistamines. So you have to start with antihistamine. Steroids is a very important option because you want to decrease the airway edema. So methylprednisolone 1 to 2 mg per kg you can give. Antihistamines IV is also available, like in hydrogen. So these are some of the things what you can consider in this patient. And if the patient, here the patient is in shock, so you will obviously treat the anaphylactic shock with adrenaline. You start off with 1 microgram per minute of infusion of IV adrenaline. If you're not able to get an IV access, at least an IM dose of adrenaline, makes sense. So these are the options which is available. And by chance, the same scenario, if the patient is, does not have any history of suggestive that this patient had a, like it's not an insect bite, it's not a, as this case scenario had a patient took a nut and then developed edema. So the other set is a dreadful complication, angioedema. So in that angioedema, the principles remain for the airway remains the same. But why I told you that history is important because if the patient is angioedema, your antihistamines, your adrenaline or steroids does not make any sense. It is not going to reverse it. So in such condition, you will have to use your C1 esterase inhibitor concentrates if it is available. Most of the time, not available in most of the setups. Then at least you can use your FFPs. So using FFPs, is a very important aspect when you are getting a patient who is non-histamine related. That's mainly a bradykinin-induced angioedema.
Thank you, Rohan, for that extensive overview. To end, we would like to discuss this particular child. A 60-year-old Down's boy presents to the ED. Fever and cough for 3 days, hurried breathing and decreased responsiveness for the last 1 day. As you do your part, you will see that the child is just diagnosed, drowsy with no eye contact, increased work of breathing. There is extensive retraction both intercostal and subcostal. Child is tachycardic, incompensated shock and hypnic as well. Child is hypoxic and the blood sugar is normal. You however realize that this child requires regulated airway. Children with special needs. Under this umbrella, we have cerebral palsy children, children with craniofacial abnormalities and Down syndrome and some such. There are general challenges and challenges specific to each of these scenarios. Sunita, with your background and extensive experience, please take us through this.
So the syndromic children, there are about 50 syndromes. And as emergency physician, we are not restricted only to the pediatrics. We extend to each and every specialty. It is not possible to remember all the syndromes. But we definitely learn to assess the difficult airway in any baby which is coming to us. See, we are acute physicians, we take care of the immediately and then we will hand it over to the other people. So what we have to know, we have to know whether we can align the axis. To align the axis, we should know the head, the shape of the head, the various sutures which fuse in a different point of time give rise to the altered anatomy of the head. That is one thing. You look at the head. If head is abnormal, maybe that you will not be able to align the axis. That is one indication. Second is look at the nasal bridge, which will tell you the baby may be having a syndromic face. And flattened, the whole face is flattened, which you see usually in the Down syndrome. You have Down syndrome is trisomy 21, you have trisomy 18, you have trisomy 13, you have 50 syndromes are there. So, and then you look at the chin, the pointing chin and the space below the chin, which indicates the space available for the tongue inside the mouth and whether you can extend or flex the neck. So these are the things which you have to check to find out whether I will be able to intubate the baby or not. It may be Treacher-Collins syndrome, it may be trisomy 21, it may be trisomy 13. There are many things. And these babies, they don't come to us with the usual problems. It may be their heart problem related, because of that they have gone into respiratory depression. the right left to right has changed into the right to left shunt. There are many reasons for which they have come and they require intubation. For us, we have to know that how easy or how difficult the intubation will be, which you can assess by looking at the facial features and the shape of the head. Once you analyze that, you should know that in children, a baby which requires 4 size 2, if you land up putting 3.5 size 2, you are increasing the resistance by 16 times as per the policy now. So you have to be very careful in choosing the size of the tube. And also you should know that the subglottic area is the narrowest portion in the children. A tube which passes the vocal cords may fail to pass beyond that. So you have to be prepared with the, see, you can't put a bigger size tube, you can't put a one size small tube also. Either way you are compromised. So the pediatric intubation always is a challenging. As I have already told you, in ER it is an uncontrolled environment. Whatever may be the syndrome, I can look, if the baby is responsive, you can do a mammography, which means if the baby is coming requiring intubation into the ER, it is very unlikely you will be able to do the mammography. Rather than that, I would prefer you doing coronary scans. Okay, give a small dose of, as I have told you, 0.25 mg ketamine per kg and 0.5 mg propofol. You just already, because of the hypoxia and hyperthermia, obtunded baby is there, very small dose will make you put the scope very aramse and find out whether you are able to see the cards. If you are able to see the cards and you want to make intubation more easy, more comfortable, that time you can use the short-acting muscle relaxants and you can go ahead and intubate this children. It is not possible for us to know all the syndromes and all the features of the syndromes, but it is definitely possible for us to analyze the difficulty in intubation in any syndromic child and go ahead with this. Unlike in anesthesia, where intubation is not the end for an anesthesiologist, because they have to monitor for the whole of the intraoperative period. But whereas in emergency medicine, it is intubation is a challenging, at that point of time, intubation is a curative procedure. Whereas in anesthesia, it is not a curative procedure, it is a supportive procedure to support the surgery. So this is how I think we should go ahead with the intubation. And of course, we should have all the equipments that is available to us. The ultimate is fiber optic scope, which may or may not be available. If it is available also, we should be able to recognize in which patients I will go ahead fiber optic as a first choice. That is also very, very important decision making.
Thank you so much, ma'am, for those teaching points. So we have 1 minute from each of the panelists where I would ask them, what should my assessment and preparation be for any emergent airway management, regardless of the seemingly difficult that we saw in these case scenarios. In general, assuming that every airway is a difficult airway, what should be my general assessment and preparation in a brief manner? We'll start Dr. Karthik in a minute. Please tell us what you would do.
Airway is the most important part of resuscitation. So definitely this assessment preparation is very important for sport performance. So most important, as we know, the 11 criteria what we follow in the emergency departments. So we look actually to see for the maxillofacial traumatic injuries, silent seizures, inter-incisional distance, 5 meter distance, and we also follow that melancholy scoring system, whether the neck is moving or not. So there are so many prediction tools that are available in the literature, but in 20 to 30% of the patients, even though all these tools are negative, but still we can encounter a patient with a difficult airway. So there should be a structured approach that should be followed in the EDs, if in case anything arises. So coming to the preparation, definitely that is very important. We should prepare all the necessary equipment like intubation, induction drugs, sedative, paralytics, and all the necessary equipment, laryngoscope, brake, and you should prepare the patient and other equipment like cardiac monitors, IV line to the patient. And most importantly, you should discuss with the team regarding the intubation plan and what we should do if there is a failed intubation, what are the necessary steps that should be taken in terms of the failed airway.
For me, we have received the patient from the ER where they felt okay, it is difficult and shift to ICU and immediately we do something. Particularly this, when we discuss this dynamic care mobilization, anterior medial mass. This is one way of evaluate dynamic care mobilization. So when you just give a minimal anesthetic dosage, that will worsen the scenario. The airway is going to be totally blocked with the gravity and all. So those kind of scenario, we should have some adequate process what we are going to do. And some patients, they came with some sort of vague, like swelling, some source of infection. It is not so bad when they are admitted, but on the floor it is increased. Overnight it becomes more and more like fluid angina. That is one scenario. Because there the problem is like one, you are not able to like ventilate and intubation is a bit difficult, this OP and all. But when you make an attempt, if it gets ruptured, so then it is gone. It's like it is going to entirely aspirate their pus, their some sort of blood mixture pus, again it makes the scenario very, very difficult. So we need to prepare with one preparation, one quickly we should have a disease specific preparation. Both are very, very important for me. So then we can bring down all these things.
So the important key thing for my practice is preparation. So preparation for me is I do the preparation. Don't depend on anyone. So if you have done the preparation, I think you will not have any problem. So you go check the suction. You go check the laryngoscope. You see the bed trolley head is going to go up or down. You see the drugs are not expired. You see the IV analyzer. So the time you say, sister do it, it might be right most of the time, but the time it goes wrong, you are in stress. So the preparation for me at least is you do it. Don't depend on anyone. Please go check everything, do it on yourself. You have a plan, I fail in this, what is the next I am comfortable with, not what the recommendations say, what you are comfortable with. So we might say do this step next. If you are not comfortable using the device, you are still wasting the time doing something if you are not comfortable with. So don't, whichever your instrument you are comfortable, you have a good experience with it, you do it. And always have a backup team, backup member who is better than you or equal to you, or it might be a junior who just help you. So don't do an airway single-handed. So it's very difficult because in the minute procedure, just giving a burp maneuver itself, it can be a life same procedure. But if you don't have any help, who don't know what to do with burp, the whole situation gets destroyed. So please involve your team. You kindly get involved in it. Don't expect your staff members just say, I want to intubate and go to the head. Nothing will work. So you do it, you get what height you want the patient's bed to be, you have to do it. How does someone else know what height of the bed? So all these things are matter because preparation, if you have done with your preparation, your procedure will 99% will not fail. That is what I have learned with my experience. So only time you have failed is you are not prepared. So with the airway you prepare, you will not fail. But yes, there are situations with all these things you will have some problems. So that's why you need an expertise. And as as students, please keep practicing these things on your mannequins. That is the only way you can be confident when you have a life situation. So it might be a surgical defect or intubation or using your devices. So keep practicing on the mannequins. I think that will solve most of the airway challenges.
So as highlighted by them, I also consider any airway intervention as a challenging only. Though you may be malapatti one, you may see that the patient is still very alright, you may end up with a difficult intubation. So it is always, if you are preparing for the intubation, you better have a backup plan. Call the anesthetist or call your colleague, somebody who can assist you. This is one thing. Second is you should have every day morning checking of your airway equipment. Airway equipment separately put in a box with all the, if you have a video laryngoscope, with all the equipment, all size tubes available to you. And each and every nursing staff should be aware of where it is. And they should not be running around for sake of those equipments. And that should be checked every day morning by the emergency department doctors. Don't think that the sister would have checked. It never happens. And thirdly, everyone in the department as a team should be using the available equipment in normal patients to get the hand of the equipment, to use the equipment when it is a difficult situation. It should be uniformly trained. And also, however uniformly you train or whatever you do, we become comfortable with one particular thing. I like red, you like blue, they like yellow. So like that, I become more comfortable with one kind of an equipment. You can start off with that equipment itself. And the moment that use of one tube has happened, replacement also has to be taken care of. So maximum medical legal cases, at least in anesthesia, it is due to the failed airway. Failed airway intubation is the maximum closed claim routes, the claims which has happened because of the catastrophes, and they have issued judgment saying that the failed intubation was due to the negligence, and the maximum cases are because of the failed intubation. And the failed intubation is a known thing, and intubation is a very acute in emergency when compared to the theatre. So the preparation is very, very important, and in those 5 beds where we call it as 1 or 2 beds as the red beds, you should have sufficient space at the head end so that you don't ask somebody to pull the car after they come. And attachment of the monitors. See, in yourself, if you are not able to do, you should know where what has gone wrong, with whom you can get it done simultaneously. Simultaneously becomes very, very important because we can't do one after the other and buy a lot of time. If that were to be there, intubation might have not been required at all. So this is how I feel in an emergency department we should go ahead with preparation of intubation.
We were very fortunate to hear from 3 groups of people who managed the airway. We had emergency medicine, anesthesiology and critical care, and I think we are very fortunate to hear from them. I think I can summarize in very few words. Essentially, it all boils down to preparation. If your preparation is appropriate, you are less likely to end up with a failed airway. And planning should include calling for help. It should never be ideal intubate, it should always be real intubate. And in addition, we can add on 2 more P's, the prerequisite knowledge. Having prerequisite knowledge of some of these special circumstances can be very helpful when you end up seeing them. Because as a routine, we are only seeing patients where you do a routine RSI and suddenly the 10th patient which comes in is a special circumstance, it can be quite challenging for you. So having the prerequisite knowledge helps, and also please consider the physiology and how you can alter your airway management. I would move to the audience. If you have any questions for the panelists, please do ask.
Points I can add. One thing is, it has been said actually, you take travels so that travels would be. So you should have all the trolley, and as you mentioned, check yourself travel. Having a good assistant is also very good. What we manage inside routine management in here is entirely different. Here, patient comes in a compromised state, hemodynamically unstable state. So in this patient, 98% of the time you can manage with our bag mask ventilation. You can manage. Only 2% of the time you require for intubation. So these patients, when they come, don't jump start for intubating. First, get everything ready. And one of the other things which we want to tell is, which we found useful, is in these patients under sedation or some local anesthetic, you can do one what is called awake look. As I mentioned, it is small dose drug, they mentioned, you and all you can do. With the local anesthetic also you can do. Have a put the laryngoscope, see by yourself. That gives a lot of information how is to be go or what management you have to do. It gives information. Second thing is, especially disabled children whom we see, they have sometimes sensitivity like to the rapid acting relaxant or short acting relaxant, such as methonium, that it is contraindicated. They may have some neuromuscular disorders. In such patients, what we have found is rocuronium is also equally good. If in saxamethonium you can intubate retrovariant, we can intubate in 1 minute. We can do that. And the rapid sequence intubation, what has been explained, now we have the modified rapid sequence intubation. With gentle ventilation, you can give oxygen and you can intubate the patient. And as I said, the Sellis maneuver, which is also controversial, you can do Sellis maneuver, and if you find difficulty in saving the patient is more important, you can just relax and pass the endotracheal fluid. So pre-oxygenation is very, very important in this patient. In emergency situation, even with issues of few vital capacity breath, we can pre-oxygenate and then we can prepare. So preparation is very, very important, and always a backup plan should be there. Not go with one technique. You should have another technique. If one fails, like the vertex, what they are describing, you should have LMAs, you should have this cricothyrotomy as a last resort, and one more resistance, like with the one person holding the mask, other person ventilating. So these are the few points that you should remember.
Thank you so much, sir. Any comments, questions from us? Ma'am.
First of all, I would congratulate Dr. Hari and all the panelists out here. It was a wonderful mix of cases. Situational awareness is very important when you are dealing with airway. It is preparation, it is definitely, but situational awareness that I should stop and give way to other person. That is very, very important. And most of these audits say that it was I, me and myself which killed the patient. So this is one thing I would like to bring to you, that sometimes as a postgraduate student or sometimes even at the senior level, this is a wrong word, but excuse me for that, the ego of that I should do it gets it difficult for us, for the patient. So kindly involve. The other thing is a criteria which is recently being taught, which talks more about the medical issues rather than the anatomical issues or difficult area, which is HELEP criteria. I think so that is also something which would help the emergency doctors to learn when the airway is medically compromised. Though your presentations have those sort of cases also. So thank you so much. I really enjoyed listening to this.
One more point which you have mentioned, ETC work monitor is very, very important in this patient. ETC work monitor. That is the only thing which is confirmatory. And as they said, in the close claims, maximum claims were because of the loss of the airway management, losing the patient. And whenever you are in doubt, because many times we think that monitor is faulty, but actually it is showing correctly. And whenever in doubt, remove the tube and go for the other management, and then confirm the tube is in with the ETC work monitor.
I would like to add one more point. See, when we are intubating, you do a scoping, and then when you are not seeing, you do the same thing. Don't do that. What went wrong? What extra I should do now? Should I put a pillow underneath? Should I put a roll under the shoulder? Should I do a head down? Should I do a head up? Some thought should come to you which will make you see the oral cuts. 101 times you keep on doing the scoping in the same position, in the same way, it is not possible to secure the airway. This thought should be there, and with every attempt you should analyze what change should be made so that I can next attempt I can see the oral cuts.
First attempt is always the best attempt. And moment you do repeatedly trauma, then you will lose that. Always get yourself prepared and
Just a comment from ICU perspective. When it comes to like intubation timing, okay, so is it a right time, is it a right indication for intubation? Many times my residents will give an answer, the patient is conscious, talking sir, you can wait sir. But if you say the pH is 6.9, we'll have such scenario. choosing an appropriate indication timing is very, very important, particularly in around critical indication. So it's not okay, they are speaking with 20 ml double strength with lactate of 15 doesn't mean. Because intubation not only helps in protecting the airway, it also takes care of their workout breathing, because in a septic patient, in a shocky patient, the oxygen consumption from the tachypnea, the respiratory muscle is going to be like many times more as compared to the calm down patient. If you do that adequately in a timely manner, so that helps in redistribution of this perfusion to needy vital. So that like very, very important in terms of that.
So, when we're dealing with the airway and talking about this much about maintaining airway and taking your human place, we need this thing, so much of concentration on the pre-oxidation element of this field. So I just want to ask Dr. Harish a question, like, is there any difference by the literatures or by the studies, student studies, like there is difference in pre-oxidation with an animal, what you do ideally, and with a CPAP, with a non-invasive mask ventilation, when the patient is on and just continuing with a controlled pressure, like continuous positive airway pressure, rather than doing with any differences there, or it is the same?
Difference is there in terms of backup evidence also. So ideally, if a patient is already NIV mode of ventilator, so it is better to continue with like experimental volume somewhere around 6 to 8 ml per kg if you are able to achieve, and give a sleep of around 6 to 8, that is CPAP or maybe kind of, and keep 100%. So data is there. Like going ahead with the some sort of in a controlled way with a fixed respiratory rate. So with the like already connected NIV from mechanical ventilator as to the combo, because see, when it is going to be an emergency scenario, so you don't have any control on the pressure which you give from the arm. So many of the beginners, they are very enthusiastic to like this kind of stuff. So when we give some sort of positive pressure in an episode way, so that will translate into increase in intrathoracic pressure, intrapleural pressure. A sick patient, when there is an increase in intrathoracic intrapleural pressure in a very bad way, so that will compromise the venous reflective right side of the heart. So ultimately it will compromise the cardiac output, and they are more prone to have unstable hemodynamics. Again, see, suppose if your requirement of intubation is for ARDS, so when we consider doing an UMBU, so we are totally breaching our non-protective so-called ventilation. There is no control. So if you do UMBU, the delivered tidal volume may be 10 ml, 12 ml, more than that is going to be. So suppose if you set a ventilator parameter with 100% effluent, the properly fitted mask, you have a gauge, okay, we are not harming by giving something called voludrama, barodrama, ongoing kind of. So particular patients, particularly this ARDS patients, definitely data is more towards like you put them on a fixed parameters of what we are delivering when going for an episode. Later in terms of oxygenation, pre-oxygenation, we got lots of data, okay, to do oxygenation with a nasal cannula with NIV overhead. So I-flow nasal cannula with NIV overhead. So there are good clinical trials which show the sustainability of that desaturation time. It's like that we can prolong if you add on like one more additional source of oxygenation during the pre-oxygenation. The take home definitely the data is more towards like going in a controlled way and more than but the only thing is like where we are expecting like air resistance signal, okay. So then you need to play with some external pressure, okay, you need to close the peak wall. So you can go over the peak in the ventilator also, it's possible. So when we are putting CPAP on peak. So those are the only
now request Dr. Shakuntala ma'am and Dr. Ashma ma'am to kindly felicitate our panelists. Thank you so much. Thank you so much, Shakuntala ma'am and Ashma ma'am, for gracing the stage once again. Now I would like to request Kalpana ma'am to felicitate Dr. Hariprasad. So Hariprasad sir is lucky, he's gotten felicitated by all three. So congratulations sir, and thank you so much for being with us today. So moving on to the next session. Next up we have the very young, the very energetic, the very dynamic Dr. Durga Prasad Reddy sir. DP sir, as we fondly call him, he is a renowned and highly accomplished PTDS surgeon and is our next speaker for today. He is here to enlighten us on the topic of pediatric cardiac emergencies. And who better to moderate this session other than our head of cardiology, Dr. Vydehi sir. And along with us, we also have respected Dr. Vijayalakshmi ma'am, who is from, who is a HOD and professor at SDMCMSH. May we request DP sir to get started with his talk and the moderators to come forward.
Tienes el cabo que
Good afternoon. So lunchtime, sleepy, and lunch. Shall I come down and speak? You don't mind? I can't see the screen otherwise. I need to talk from down. So most of the year they wanted me to talk on thoracic from us. For a change we have done as a pediatric cardiac emergencies. So let's see. I come down and speak. You don't mind? Is it okay for the all? Yes, sir. Okay. Before we start, we'll share our experience a little bit. We have done close to 6,000 pediatric cardiac surgeries. Emergencies have been taken as 10,500, including CATs and procedures. And TOP is one of the biggest series in India we have. We have around more than 1,000 TOPs, total corrections we have done. Our mortality is less than 2%. So, introduction, pediatric cardiac emergency is most stressful in India. Usually it is connective disease. We have to think about only two things in connective disease when we talk about connective disease. Cyanotics and acyanotics. Acyanotics is very easy to treat because acyanotics usually what happens is they come as a recurrent respiratory tract infection or they come as what you say is they come as a complete flooding on the lungs. So it's very easy to treat acyanotics. Cyanotics, they come with spells that I will discuss later. So these patients are often complex, and whenever a child comes to you, and the child is always, you have to look at it very carefully because it's very difficult to understand what the child is about. What the child will be crying, irritable, the respiratory is not less than 40, and cyanotics. Usually the cyanosis you have to look at because most of the Indian child is cyanosis not in differentiate. Where you have to look at the cyanosis? You know, they say you have to look at soft palate. Very difficult to open the mouth of the child and see. So quickly see the nasal, take a nasal statement, look into the nostrils, touch it, you'll see a bluish blue. This is what you will see in a child when a cyanosis is there. And when the child is crying, the saturation comes down, that means it's cardiac. The saturation is improving in the respiratory. So, and always look for area pressure. transposition of coronary arteries, pulmonary arteries here, truncatus arteries. Time permits, I'll go through everything, but top I think I'll speak in detail. So when we talk about technology, most of the persons say the VST, there are 4 components in technology. That's the VST, right hypertrophy, overriding of aorta and pulmonary stenosis. They are components of technology. When we truly talk about technology, what we see is in technology is always a large maritime VST. This is how it is. A VST which is very large, the complete angles of the aorta seen through the VST, and the pressures in the, and of course there are RVOD obstruction, and the pressures in the RV, LV, aorta should be deep, but only then you call it as a technology, otherwise it's not a technology. Mere small VST and PS is not a technology. It's technology like, but it is not a true technology. The pressures in the aorta, RV, and LV should be equal. So clinical findings, the child is cyanotic. Cyanosis, as I said, clubbing. Usually the child crosses 6 months, they'll have clubbing. Most of the Indian children you see with clubbing, they all have nail polishes. They put a saturation level which was very high because saturation always picks up the color of the nail polish. So make sure the nail polish is removed, check for your saturations. And cyanosis, nasal speculum. Always the EMB should have a nasal speculum. Central cyanosis, always use a clip saturation to put it on the earlobes to check the saturation, especially in children. Otherwise, they're not going to let you put your probes in your fingers. And recurrent respiratory tract infection. In acyanotics, it's very common. Cyanotics, they say it's uncommon because the blood is not flowing much into the lungs. That is what is the concept. But we looked in a different way. All cyanotics also have recurrent respiratory tract infection. The reason is the important function of the lung is not only taking in oxygen and giving out carbon dioxide, not the gas exchange. It's also a phagocytic action. It also removes the bacteria. In technology, what we see is there is very alveolar units are very little, so the phagocytic action is not there. So children get into recurrent respiratory tract infections even in cyanotics. And always on examination, pulmonary area, it is single S2. PGs, how many PGs are here? EMP or PGs? Single S2 in pathology? No idea why you with single S2? Cardiac PG? Narrative? No. Okay. Single S2 is because it's pulmonary stenosis. There is overriding of aorta, that means the pulmonary artery is slightly posterior. So we always get what you hear the single S2 is the aortic component, not the pulmonary component. And the injection systolic because the blood is gushing out in a small hole. X-ray, you get a bone-shaped heart. Always the pulmonary vein is concave because not much of blood is going into the pulmonary artery. And because of the tight stenosis, there is diabetic hypertrophy and lifting of the right ventricle. It appears like a boat shape. And in this is what you see. What is stress? Unity of thought says, when the child is irritable, tachycardia, lot of adrenal surge is happening. That adrenal surge will produce infantile spasm. I think that's a old concept. We don't anymore follow that concept. The theory is not allowed, especially in pediatric cardiac follow through. What we see here is whenever the child is crying, irritable, tachycardia, the heart rate will be more than 180. So what happens naturally, everyone will get into systemic vascular resistance comes down. That means all the blood is happening is more right left shunt. That means all the blood from the right ventricle to left ventricle is moving and it's all is taken into the aorta. Nothing is going into the pulmonary artery. Completely the blood is moving into the aorta and gets pulled into the thing. When it repeatedly happens, what happens? The child becomes acidotic. Once the child becomes acidotic, starts breathing excessively, hyperapnea happens, change of breathing, hyperapnea. Once there is hyperapnea, what happens? The systemic venous return is more into the right atrium. That means the negative thoracic pressure increases and more of blood is coming into the RA. More of blood is coming into the RA, more to the tricuspid valve, into the right ventricle, and more again into the left ventricle, into the nothing is going into the pulmonary artery. So this happens as a vicious cycle. So the two reasons out here, decreased systemic vascular resistance and increased systemic venous return. So these are the two culprits you need to tackle when you have a cyanotic stress. How do you tackle this is, you need to break this mechanism. How do you break this? First thing when the child arrives, put oxygen and put the child on knee chest position. Why do you put on knee chest position? Because the moment you put the child on knee chest position, it compresses the femoral artery and it also compresses the femoral vein. By compressing the femoral artery, the systemic vascular resistance is raised, and by compressing the femoral vein, it decreases the systemic venous return. So by doing this, what happens? The blood is forced into the pulmonary artery. So you have to do this repeatedly at least for 1 minute. You need to hold it. Then check for the appearance of ejection systolic murmur. That means the child has come out of cyanotic stress and lessening of cyanosis. Both should be observed. Once appears the ejection systolic murmur appears and the cyanosis decreases, that means the child is becoming better than cyanotic stress. So this is the knee chest position. Keep it for 1 minute without this one. Don't keep moving and up and down. That doesn't work. You need to compress it for 1 minute. How do I play this? Alright. Oops. Can you go to my slides for me? From position. It's okay, doesn't matter, leave it. You show the slideshow, doesn't matter, I manage. All of you are aware of all the ejection systolic murmurs. This is how it peaks up. Okay. So once there is no appearance of murmur or cyanosis is not decreasing, so what we give is phenylephrine, which is alpha blockade or propranolol beta blockers. So that will decrease the heart rate, in turn also increase the systemic vascular resistance. IV morphine, it abolishes the respiratory center by decreasing the tachypnea. Also ketamine is also a very good drug to increase the systemic vascular resistance. IV soda bicarbonate to reduce acidosis. Refractory spells, put the patient on ventilation, and we should plan for an emergency procedure. Before planning for an emergency procedure, what we do in ECHO is something called as the Magoon's ratio. Magoon's ratio is nothing but a sum of a ratio of diameter of LPA and RPA just before the branching. Can you see that? Just before the branching, divided by descending thoracic aorta at the level of diaphragm. Normally, a Magoon's ratio is 2 to 2.5. Suppose the Magoon's ratio is less than 1. Main pulmonary artery is half a centimeter. What we do is modified VD shunt between the subclavian artery or aorta into the right or left pulmonary artery towards thoracotomy. If Magoon's ratio is less than 1, main pulmonary artery is 0.4 millimeter. Central shunt we do between the main pulmonary artery and aorta towards thoracotomy. Magoon's ratio 1.5. PA 1 centimeter, we do a total correction, what we call as an intracardiac repair to a surrounding. But 1.5 is borderline, but when the PA size is 1 centimeter, it gives a good result. If Magoon's ratio is 1.5, PA is 7 millimeters, the results are just borderline. So always be very careful in this Magoon's ratio. 1.8 Magoon's ratio, safe. 1.5, always check for the PA size. So, can you see the shunt here? This is the central shunt, what we have done. We connect the conduit, which is 5 millimeter or 6 millimeter conduit from the aorta to the pulmonary artery. That means you are diverting the blood from the aorta to the pulmonary artery directly, bypassing the stenotic area, so that the patient improves in cyanosis. This is the concept. And also, to increase the size of the pulmonary, because more flow is happening and the size of the pulmonary artery increases. And later stage, as a second stage, you do an intracardiac repair. But by doing this, what happens is, most of the time what we see is this direct connection to pulmonary artery. There is more flowing of blood into the pulmonary once there's more flooding, patient gets into volume over kind of situation. So this kind of a situation, we always now we don't do a direct shunting. We always make like a U loop from the aorta to the pulmonary artery. This was actually done by one of the residents who was working in emergency. This was seen in Leipzig. The concept was constituted by Konsari, but this girl was saying, why don't you put a room so that why you take a course and put it to the pulmonary? Very innovative thing to understand. So nowadays we started doing this. One problem what we face by doing this is it is never parallel to the heart like this. It always jets out. So closure of the sternum is very difficult. So what we do is we make a loop into the sternum and connect it. We tie it to the RA appendage. So this always remains parallel to the heart. So how do you manage cyanotic stress intraoperatively? Just before going on a cardiopulmonary bypass, patient can become into cyanotic stress. So what we do is we give IV phenylephrine, soda bicarbonate before we go into a stun. Also clamp the ascending aorta and the inferior vena cava for 5 seconds so that it forces the blood. That means you're increasing the systemic vascular resistance and also decreasing the systemic venous rhythm and force the blood into the pulmonary arteries and proceed to cardiopulmonary bypass. Just to say what is cardiopulmonary bypass, we do what we do is we drain blood from SVC, IVC to a YE connection, we collect it from the reservoir, get it oxygenated and push it back into the aorta. So that the heart is beating, empty, and also we put a cross line and we give cardiac just so the heart stops. And so that we can do the procedure what is required. So this is the aortic cannula where the blood comes in. This is the superior vena cava cannula, inferior vena cava cannula. We take the blood, goes into the reservoir, comes back, oxygenated blood into the thing. And this is a redo where a shunt, central shunt is done. Can you see central shunt has been, this has to be ligated before we come to the cardiopulmonary bypass. With central shunt open, we go on cardiopulmonary bypass, the whole thing gets flooded into the pulmonary artery. So always ligated before we come to a cardiopulmonary bypass. So surgically, choose sternotomy for the option. The approach is in different modality. What we approach is we close the VSD and infundibular stenosis through right aortotomy through tricuspid valve, pulmonary valvotomy through pulmonary arteriotomy. So, what do you mean by total correction of pathology? This is infundibular resection. One should understand why there is infundibular stenosis, because the infundibular septum, what happens, it moves and obstructs the pulmonary artery. That means it moves superiorly and anteriorly. It is not, and the defect is not just a hole in the septum. The infundibular septum moves towards the superior and anterior and occludes the right ventricular outflow tract. And we close the VSD with PTFE patch, do pulmonary valvotomy, reconstruct the trans and the organ state. Can I play this? Someone? Can I play this video? Can I press this play? To play? Okay. So this is infundibular resection of a pulmonary valve. Can you see how infundibulum is moved into the alveoli and obstructing the complete right ventricular outflow tract? Excise the infundibulum as much as possible. This is the infundibular muscle we are excising. Can you see this muscle there? This is a VSD here. The infundibular muscle is completely excised. And fashion a patch. This is a PTFE patch. We take it, we always guess what is the size of the VSD. It has to be the size of the aortic annulus. We guess it. We make a nice oval patch. We place the patch. The first stitch has to be inferior border. Make sure you don't go deep into the margin so that avoid connection there. Can you move the video a little bit? One of you can stand there and move the video to movement. This is a VSD closure with a PTFE patch. We take continuous stitching. Quickly I finish the video because this will be boring for you guys. You press the thing, there's a cursor comes, you can move the video a little bit. right atrium. Can you move the video? So once the VSD is closed, can you move a little more? Move a little more somewhere. Now it will move. Okay, forget it, no. This takes time. That's why the review is a full video. It moves. Actually, if you press that, there's a thing which comes. You move the cursor there, it comes. Okay. So once the VST is closed, you know pulmonary valvotomy and close with the underlying patch. It's okay. Don't worry. The video, surgical video was going to go in for now. Don't worry, don't worry. Leave it. So you have to be very careful when you take the inferior aspect. Don't go deep. Don't come out into the VSD. You have to be very careful there. So once the VSD is closed, you also check for the leak of the VSD by doing kind of measure there. So you see a lot of blood is intact. It's not coming into the VSD opening. Then it is water directly switch. Once that is done, you open the pulmonary, RBOT is open. First you open the pulmonary artery, extend into the right ventricular outflow tract. You see this? Any excess muscle is exercised through the right ventricular outflow tract. The most important thing is excision of the pulmonary artery valve. The pulmonary valve, what we do is we retain the posterior pulmonary valve and the lateral aspect so that the free PR is prevented. The reason why we have to prevent free PR is it's long term we can maintain at least over 20 years we can maintain with moderate PR. Severe PR we try to avoid. Then we size the agar with RDOT. Usually, suppose for an example, the agar is 8 to fitting. I put 4 size extra, I put 12 agar size. Make sure the opening is 12 size more. And close the RBOT reconstruction with the orthodox pericardial patch. Make sure the orthodox pericardium is washed well, and if it's severe pericarditis, because we store these patches on glutathione. Glutathione is a very sensitive and very irritant test. Next is total anomalous pulmonary venous connections. Here all the pulmonary veins forms a confluence and it's not draining to the head, it's all draining to the eye. So this is all ECS. So the presentation in here, the tachypnea, profuse sweating, especially the forehead is sweating because of low cardiac output. Cyanosis, this is the only condition where a child is present in the cyanosis and the severe pH. Because all are draining into the sun, increased flow across the pulmonary valve and failure to thrive. And what on putting a step in the pulmonary area, what we find is cortical rhythm, that is S2 is widely split and fixed. Why S2 is widely split? You and me have a narrow split because during inspiration what happens is some amount of blood going into the pulmonary artery, the P2 process much later than this only in inspiration. But in TAPC what happens, there is more blood coming into the right atrium because all the pulmonary veins are drained directly or through a connection into the right atrium. And more blood across the tricuspid valve into the right ventricle, and more blood is going out of the pulmonary valve. That is what we call as prolonged RV ejection time. That means the time taken for the valve to close is delayed and it's also fixed because throughout the respiratory cycle there is no change. That's why the S2 is widely split and fixed. And you also get mid-diastolic murmur at the tricuspid valve area because there is increased flow across the tricuspid valve because it's a relative tricuspid stenosis. And the same, similarly, there is increased flow across the pulmonary valve producing injection systolic murmur. Echo LA is empty without any pulmonary veins. All the venous, pulmonary venous connections are into the RA, whether to the coronary sinus or to the confluence through one of the connecting veins, what we call as the vertical vein or descending vertical vein, into the superior vena cava or into the inferior vena cava. X-ray of TAPC supracardiac EMG. What do you call as a snowman sign? See, the LA appendage is not full because there's not much blood coming to the area is empty usually, and this is the LA appendage area, it's empty, and the contents is just behind, and it connects to a vertical vein into the innominate vein. So more blood is flowing into the innominate vein, dilating the innominate vein, and that in turn dilates the superior vein. So it forms like a snowman sign. So how do we manage this medically? The support ventilation is required, antidotes, digoxin, dobutamine to decrease the pulmonary pressure, diuretics. ECMO is also practiced because once the lungs are completely flooded, the results are very bad. So we control this by performing an ECMO, VA ECMO, and then you make sure the lungs are cleared up and then plan to a surgical procedure. What we do surgery is we connect the confluence where all the pulmonary veins are running into the LA appendage by side-to-side anastomosis. Most important another presentation Al-Kappa, where anomalous left coronary artery is seen from the pulmonary artery. Very rare situation. Our experience, we had almost 5 cases of Al-Kappa. We lost 2 because in infancy the results are very good. If they cross the infancy, the myocardium becomes intramyocardial fibrosis because repeated infarction they had. So always, we have to catch this at the right moment. At infancy, Al-Kappa very good 100% results. If they cross the infancy, they go to 4 years, 5 years, the results are very bad. So usually the infants born are asymptomatic for 6 to 8 weeks because the pulmonary vascular resistance is very high, up to 6 to 8 weeks. Once the pulmonary vascular resistance drops down, what happens is there is more flow of blood into the pulmonary artery. Once the pulmonary artery takes up more blood, all the deoxygenated blood is also supplying the coronary, which is arresting the pulmonary artery, and the child experiences a myocardial infarction. How is it presented? The child doesn't complain of a chest pain, irritable, continuous crying, turbulently, get an echo as soon as possible, which shows the cardiomegaly in severe pain, sometimes MR because of myocardial infarction, congestive heart failure. Always check for the central edemas. ECG, myocardial infarction, ischemia, cardiomegaly, X-ray. Echo shows dilated LV, global echinacea, MR, dilated LV. CAG is gold standard, they say, but very difficult to perform. Now CT angios have come. We can do a CT angio to delineate where the coronary is because this is not always anterior or lateral. Sometimes the coronary is arrest from the posterior aspect of the pulmonary artery. So always better to do a CT angio. Coronary angiogram is gold standard at first, but very difficult to perform in children, infancy, cannulating the femoral arteries and other things. It's high risk. Best is to put a IV cannula, get a CT angio, delineate the coronary where it's arresting. Cardiomyocyte is 30H. Sorry. So what we do is we treat the failure, and also it's an emergency surgery where we reimplant the LC organ into the aorta. Can you see this is a coronary which is arrested from the pulmonary slab, and it's very straightforward in its surgery. We just disconnect and connect it back to the aorta. Sometimes what happens, this coronary arrest is posteriorly. So we have to cut open the pulmonary artery, make a canal patch, close it, and then close the pulmonary artery with the conduit. This is what it is. PG, how do you know what is PG? The pulmonary arrest is from the left ventricle, and aorta is from the right ventricle. Sinuses, right from the day 1. These patients have VSD or ASD, sometimes absent. They have parallel circulations, running through severe metabolic acidosis, congestive heart failure, they have VSD and PDA. On examination, single S tubes, two conditions, pulmonary atresia and TGA. So echo is very important in lead. When you do echo, we find a double circle appearance or a double barrel gun appearance, because aorta and pulmonary artery are anteroposterior in relation. Pulmonary artery is posterior and aorta is anterior. It appears like exactly like a double barrel gun. X-ray echo and X-ray appearance, because the aorta and pulmonary artery are not side by side like in normal. It is anteroposterior, and usually they have very small famous, so appearing like a string, and because of LVH, the art is LVH, and it's as if the egg is hanging on a string. So, how do we manage this children? At birth, we need to make sure the PDA is kept open. Usually the PDA gets closed in 6 to 8 weeks. We give prostaglandins to keep the PDA open, digoxins, diuretics. That fades, take the patient to cath lab, do a valvular septostomy. That means the cardiac output has to be maintained. When there is no cardiac output coming out, you need to create a cardiac output by keeping the PDA open, or at least enlarging the PFO. You put a balloon across into the cardiac, pull it back, the septum becomes bigger so that the cardiac output is maintained. Surgically, TGA with intact ventricular septum into arterial switch, TGA with PDA, arterial switch with PDA-ligation, VST closure with VST. With PS, you put a RB to EA conduit. So we put a patch, we put a patch in such a way that we divert the pulmonary artery into the right ventricle and aorta into the left ventricle, and also place a conduit across into the MPA. We call it, what we call this, the LeCompte surgery or a rare procedure. Pulmonary atresia, similarly, single S2 on examination when it comes. Athletic valve, RVOT is patient's cyanosis immediately after birth, deepens after 2 days. Irritable infants with facial edema. Central cyanosis, clubbing if child survives beyond 6 months. PDA is a must for survival. In the pulmonary atresia, if you don't have a PDA, it's very important that you keep the PDA open by prostaglandins. On examination, single S2, absent ejection systolic murmur. That itself shows only two conditions. It has to be TGA or pulmonary atresia. Echo, always a pulmonary valve is atretic and thickened RVOT, immobile. CAT study to delineate coronaries. Management, again PG, prostaglandin infusion. A lot of people dilate a atretic pulmonary valve with a sequential balloon dilatation. We generally avoid. The reason is the valve, there is no valve there. It's completely atretic. You cannot pass through the atretic area to dilate that valve. If it's a stenotic valve, you can still do it, but an atretic valve, it's very difficult to perform a balloon dilatation. So we always offer a surgical, we do a modified PD shunt, the atrial septostomy to give a cardiac output easy. Or what we do is a BD Glenn shunt or a Fontaine procedure. So BD Glenn is nothing but we connect the superior vena cava into the pulmonary artery, whereas in a Fontaine we connect the inferior vena cava through a conduit into the pulmonary artery and superior vena cava into the pulmonary artery. Here we don't connect parallel to each other. Once we connect parallel to each other, what happens? The eddy current forms here. There is a lot of clogging. So we always put this diagram is exactly parallelly connected, but we always connect it a little bit to a side so that the flow is established. Thank you. Thanks for giving the opportunity. This is 1.5 day. Thank you for giving the talk on pediatric cardiac emergencies. Thank you. Any questions? I can answer.
We would now request the moderators to add their inputs.
Thank you, sir, for the informative lecture. And I want to request the young ED physicians to keep always cardiac etiology also in mind in any sick patient coming to ED, because the presentation may not be as classical as in an adult cardiac patient. And secondly, in view of so many interventions being done, make yourself familiar with the delayed complications of the intervention procedures so that you will not miss them. Thank you.
Always they have lung interactions. All these cardiac problems and lung interactions are there. They present as dyspnea, always a lung respiratory problem. There is no cardiac issues coming. So you always have to find out whether the child has got a cardiac issue.
It was a good coverage of all the common pediatric cardiac emergencies what we see in ER actually. I think one important message is identifying the problem and then probably taking it as an element.
Surgery as soon as possible.
And refer them to the concerned department and then so that the patient can undergo the corrective surgery or the palliative surgery. That's where the crux is. So identify the problem, then refer them to the correct department, means cardiac surgery. I think we can do it. Otherwise it's difficult. Especially commonly we see so many scientific spells in the ER. And manage them very aggressively, then refer them to emergency surgery also, either a PD shunt or a central shunt.
There are a lot of ER patients doing PD shunts, like in PD in the ER. No, it's done. Most of the ER patients in internationally where I worked in Leipzig, they do a lot of work, especially in pediatric. They do a ligation of PDA, they give prostaglandins, they also do a PD shunt. You know, that loop was one of the suggestions from one of the top centers in the world, Leipzig, Heart Center, Leipzig. They are the one who designed that loop.
The other subset is like TGA, what was told. TGA patients are difficult to identify.
Single S2, that's all. You put your stent single S2, nothing else it will be. It has to be a TGA or it has to be a pulmonary tracia.
So, not commonly they come to ER probably.
They come to cardiologists, that is the issue. They come to cardiologists, but I think they have to be routed through ER and through.
I think ER should be aware of this, and then probably many of the TGA babies are so sick, they'll be acidotic, and then unless until you do some corrective interventions like starting prostaglandin, trying to keep the PDA open, and then unless class is done, you'll not be able to tide over the crisis there.
Correct.
The other group of patients like who land up in ER is like PDA dependent circulations, especially hypoplastic left heart syndrome, pulmonary
These are half an hour is not enough for me. You can speak for 2 hours.
These patients I think have to be probably taken care in a different way, like starting some post-traumatic infusion to keep the
in ER itself, that's what we should see. Ventilate the child.
Ventilate the child and then
those things are important. ER patients can do a lot of things actually. You know, they can get well versed in echo. Echo is a very important tool for a cardiac. Not require a cardiologist or physician should do. I think ER patients should be well versed with echo. They can do sliding signs of the lung, so many things. So many things they can pick up for emergencies.
So be aware of all these things as discussed in the presentation. Thank you. Any questions?
Any questions from students? No questions?
Thank you for that very informative talk, DP sir. We as an institution are truly privileged to have somebody of your caliber with us. I would also like to thank the moderators for making the session so interesting and adding their inputs. I would now like to request the moderators to felicitate Dr. Durga Prasad Reddy sir. Lead consultant at Vydehi Super Specialty Hospital, Department of Emergency Medicine. May we please have you on stage now? Dr. Neelu will now be felicitating the moderators. May we have a huge round of applause, please. the EM quiz prelims are happening parallelly in conference hall 2, requesting the interested delegates to cross over to the next hall. And the rest of us will now be breaking for lunch, and we will convene the sessions again at sharp at sharp 2:50 p.m. about half an hour from now. So we'll see you again soon. Requesting our speakers for the next session and the moderators to be ready.